are the part which are going towards interpedancular fossa. It has got delivered. Now come out. This is a video is over, and this is the total removal of the tumor through the translaminar approach, and you can see this intact. Would you please stop? You have a very smooth stop. And
Oh.
Take the mic. Take the mic.
Now I proceed to my next talk. Please excuse me for changing the gear. This is about the thalamic lesions. There are many approaches that are described that shows that nothing is perfect for these lesions, but I use the posterior transinsular approach. We know that the thalamus is located deep and is functionally very important. Therefore, it is most justifiable to look at these lesions exclusively and specifically. We take posterior transinsular approach and will detail the same. The posterior transinsular approach seems to be quite suitable way to handle majority of the tumors because majority belong to these zones of the thalamus. The only small percentage which is involved in the pulmonary region should not be and cannot be approached through this route. We have to work in a difficult and unforgiving terrain because these tumors are deep-seated and they are surrounded by very important functional structures and itself is a very having great functional importance. So we expect a major morbidity. That is why these surgical treatment of thalamic lesions carry major risk to the patient and deep fear in the operator's mind. It demands careful evaluation of risk-benefit ratio. It is definitely a favor to the neurosurgical community that they are very small in numbers of all intermittent tumors. The discrepancy in the statistics is because inclusion or exclusion of the secondary tumors which are developing outside thalamus but reaching to the thalamic region. Otherwise, they constitute a very small percentage, and some reports are there even less than 1% in their series.
Right on it. He's been shot. Has he stopped breathing? Has he stopped breathing? Yes. Yes, I really have. If you don't hurry, he's gone.
Chris Lane was an Australian rising sports star, a talented baseballer on an American college scholarship.
Because a scholarship to an American college, big deal.
Yeah. Big deal. Yeah, it's how can the mother say no, don't go?
Very quickly, it fell for you.
Any aspirations to be a pro ball player sometime?
I don't know. It's like, if I stay away from the beers, we'll wait and see, but never know, flying gets away some days.
All right, there we go. Hey, mate, good to see you. All right, man. He was living his dream.
Oh, absolutely. Absolutely.
This transcercal approach to glioblastoma. The child survived for 32 months and then multiple intracranial deposits was submitted to intraventricular dissemination and she succumbed to that. This is a 14-year-old child who had a seizure from early childhood at this tumor. Total excision was done, as you can see here, and this is a rodent fibrous cystic astrocytoma. She is 9 years down the line. She's finishing her college and functionally independent. There's another child with anaplastic ependymoma presented, 5-year male, abundant presentation, total excision, complete function recovery, back to school, and these are post-operative CT and this post-operative MRI. And this is a rosette typical histology of the ependymoma. And this is the child who was this is stage in post-operative 2 to 8 weeks later, I think. This was published also in Neurology India as the original article. And this is a lady who has glioblastoma. 70% was the MIG in this patient. She succumbed to it in 9 months. Though no additional weakness beyond what she had pre-operative stage.
Yeah. Most people will go to college and try to find who they are on their own, like away from parents and all that. But I found it with Chris, and he really helped me.
This is the first post-operative day. And
so many
6
memories.
weeks later,
Luckily, like I got most of this time in the last 4 years, so I had
Thalamic glioma,
seamless
again,
amounts. So
patient
it's helpful
of this
thinking
thalamic
back on
glioma
those and not dwelling on
was
all
operated
of this. But
as a young lady.
Yeah.
She is sick
She was
nowadays. I think I have come to
amazing
know,
guy.
but it was 1.5
Do
years.
you think obviously there's been a
She's
lot
fine and
of
she's
love
working
on
on
social
her
media in
first
particular? There's a tribute
Little
page
injections
that
and
by the hour just goes up in thousands. Do you think that just says a lot about the
This
man?
patient
says everything.
recently
The
has
fact
a
that
large
people
tumor
all over
and
the world that he either met or gone to school with, or even people he hasn't met, they all love him and respected him as a person, respected him as an athlete, and
again
really truly great friend.
And what was he planning?
with help we can mark these steps on the control letter side.
We were going to see
This is a
perhaps he got
I don't know
internship
when
over
I
there
start
or
the topic,
here,
but
or
I
whether I was
just
going to
wanted to
pursue
show that
master's plan here, there, but it took a lot of
approach
time
which I
trying to
take
figure that out. This was going to be the year of planning, but which we put off this long. So
skip to this, but this is a post-operative
yeah, it was
and
all up in the
we
air.
was
at this
78%
point.
It's a very
done
personal
with the
thing, of
recurrence
course,
now.
you've been able to
We'll
speak
go for
to
our
his parents as well.
Just
How
like
did that go?
thalamic cavernoma,
I talked
which
to
are
his
operated
family
with the same procedure,
daily,
total
whether
is
it's
done
cousins,
and post-operative
sisters, or
MRI, no
parents,
disease.
and I
And
wish
the
them
patient is
that they
asymptomatic.
find some kind of
This was a
comfort.
patient from where
Help
on
and
I
heal.
got emboldened
I
to do the
appreciate
thalamic surgery
everything that they've
because
done,
this
and I
was a hematoma.
appreciate
The
you
attendants were
sharing
not
him
ready
over
for
here
the
for
death
all
of
of
a
us.
38-year-old male who came with
Can you
E1,
just tell us
E1
your
M2.
memories? Your fond
And
memories?
I
I
thought
don't
that
know,
let
he's
me
just such a,
move the let us see.
he's such a chatty
We moved in
person.
within
He could
12
talk to
hours. This
anybody
patient
about
was
anything at
E4
any
and
time. And
6
it
and
was
he died
amazing. I was always the shy
7
one that never had
years
anything to
later
say, and he could talk to
because
a
of the
wall.
chronic kidney disease.
Fine.
This is a
Nothing to talk
cervical
about.
excision
You
for
obviously love your
granuloma.
family with it as well.
Yes,
And
I'm
the
so
patient
happy
is
that I
doing
got
well
those
on chemotherapy for
5
fungus.
weeks over there with him
Sister,
and seeing him with his family and
neurocystic
place that
circus,
he
again
left
removed through
alone.
the same route.
If we go
So
back,
both low grade and high grade
one you were
thalamic neoplasms and
Or
non-neoplastic
actually, he
lesions are
asked me for a
treatable through
couple
this
of times
route.
and I denied at first. And
Post-operative
then
results
finally
rewarding after
accepted that, yeah,
tumorectomy,
the accent was
radical
the
resection is
initial draw.
curative, and
What
posterior
about
transcranial
feeling the love
transinsular
from Australia?
approach
And there's a lot of
is
support
less
coming your way over that
time-consuming,
negotiation.
relatively
It's
non-invasive,
amazing to see
direct, and suitable
the
to most
outpouring of
Canadians.
support that they've
Thank you very
given
much.
to all of us over here, not just me, but his friends and the people he's impacted
sir.
on this
Finished
side.
well in time.
But
Audience,
yes,
any questions,
really
comments?
comforting knowing that there's
Yes.
that kind of connection being formed.
The plan is for some fundraising to go home and say final goodbye.
They've all started this without my knowledge, but I appreciate all the support that they've given me.
We'll be able to catch up with his parents.
There are no complaints, asymptomatic patient, those who survived
Amazed the
asymptomatic.
least when the funeral will be.
Now, what I
and
told
then
you that all these
we'll
instructions
travel
are
over
split
there,
apart because of
pay
space
our
requirement.
respects and give our last
So the
goodbyes
fear which is on
to all of
the
them.
normal anatomy is actually not so
Anything
real.
else that you wanted to say? I mean, either about Chris or about the
There's one more question.
or about your time here.
Just
Yeah,
that
just-
he's
Sure.
such an amazing person and I'm gonna miss him
Yes, please go ahead.
forever.
Do you do technography before the
I'm really
surgery?
glad that I got
Where
to
is
see
will
him.
and must.
Not always.
Well, that's all. Thank you, Professor Mishra. That was a nice talk. I would like to talk to Dr. Dattare Mazumdar, who would also be first giving us a video presentation on CT and meningiomas and following up with this talk on.
Hey, if you want to know why literally hundreds of
thousands.
thousands of investors are getting their advice from Motley Fool Stock Advisor, well, it's simple. Our average stock has returned 368%.
kind invitation. I will just be going through a brief steps of CBNL tumor, meningioma. It's a prenatal uterus-based tumor. And here I want to just reiterate that we have strong components of the sitting position. And though we use sitting position, and we're using it quite regularly and quite successfully without any major issues. And this is a patient who was a 60-year-old female who had a who came with giddiness and imbalance, and the neurological examination was obviously normal. And she had a vitreous-based tumor which was about 3 centimeters, close the abating peak, CP angle, the nerves in the CP angle. Here you can see that the tumor is, the T2 is quite hypointense, so it's quite hard, calcific, quite hard. And you can see that the fifth nerve is pushed superiorly, the seventh is also pushed inferiorly, and lower canals are also pushed down.
4 years ago,
So,
baseball, and it was a choice that he
as
made.
we
It was
first
about
open the
15
listing, we first release the CSF from the system magna because the brain tends to be not very supple. So the first thing
a week ago,
is to
finishes this
release
one
the
break,
CSF
and
from the
turned
system
into a
magna
the guy who was lucky in his partner,
wait
Sarah,
for some time for the
for
brain
4
to become
years,
pliable.
and they were just a couple in love and very comfortable with each other. It was almost like they were married and so
This tumor is exposed
they could just sit
with the single
and know what
retractor,
the other one was
and the
doing.
arachnoid is peeled off. You can see that
And they
this
were
is
just
arachnoid.
comfortable in
And
each other's company. It was just fantastic to see. He's left his mark, as we know, and you know, there's not going to be any good coming out of this because it was just so senseless. There wasn't anything he did or could have done. He was an athlete going for a job like he would do, 5 or 6 days a week in terms of his training schedule. It's happened, it's wrong, and we just try and deal with it the best we can. His mum happened, it's wrong, and
we use the section in the right hand, and basically the section is used as the sucker at the dissector, and you can see here that usually make use of the knife, scissor, and the suction, and simple bayonet for this. So not much of instrumentation. Not much of instruments are required for this, and as we do the standard principles, first you have to just debulk the tumor to create space before going to the point of the site of attachment. And you can see that the main purpose is to just release the CSF further from the CP angle system to make it more pliable. So minor bleeding here and there is not addressed or not coagulated. We use minimum bipolar coagulation, and even though the is quite hard, it can be done without CUSA. So we will use a controlled keyhole suction so that the tumor is broken with the suction itself. And you can see that the lower canals are pushed down with this, and the interface is created between the the cerebellum, the CP angle, and you can see that in the moment you will see that the arachnoid, the anterior inferior arachnoid will be exposed. Till the time we just use plain knife dissection. And you can see that the arachnoid is seen anteriorly. You can in fact even see the 6th nerve through the arachnoid. And the whole tumor can come out. You can see the brainstem and the 5th nerve which is compressed anteriorly, and through the superior lateral angle, you can see that the 6th nerve is also seen. So sequential debulking of the tumor. You can see here that we are not using the standard technique of coagulating, cutting. It's hardly any bipolar is used. It can be done. I'm not saying that bipolar should not be used, but this is one of the variations of the technique. And some amount of blood does remain on the arachnoid, which need not be cleared. And copious amount of irrigation can be used to clear the blood. You can see that there's a thin film of arachnoid now. And as Professor Saito said, it's like using like continuous copious irrigation is helpful to identify small minerals. These are minor arachnoidal vessels which usually the bleeding stops on its own. And then I come to the attachment. You can see that the lower cranial nerves are not seen in this operation, and you need not see them. At the moment the tumor high power dissection along the seventh nerve complex is done, you can see that the seventh nerve is seen through the arachnoid here. You can see here that there's an attachment. So that attachment here, to get to this attachment, you have to really do a significant amount of debulking of the tumor. Sometimes you have to use a high powered bipolar. You can see that that's the attachment along the meatin segment. The tumor is there. Now this is the tumor which is there along the. You can see the ICA and the seventh nerve, and there is a small fringe of tumor which is that's this tumor on the seventh nerve. You can see that the ICA and the seventh nerve in close proximity. You can see that the facial nerve, and that's the ICA loop. So here you use the small microsurgical instruments to dissect off. Again, I use the same technique, the bayonet and the suction. You can see that apart from that, no other instrument is used. It can be done very comfortably.
Dr. Dattar, I think you have to wind up the video.
Yes, yes. So, otherwise the top will miss. So this is the end of the tumor. I think this is the end, and the tumor is excised complete. Thank you very much.
We now go on to the talk of Dr. Dattar, which is going to be about posterior fossa tumors, surgical nuances.
Posterior fossa tumors are commonly dealt with. I will not go into the basics of the posterior fossa tumor, but how does this impact excision? And with a lot of molecular information coming, we need to now have a sound knowledge of the molecular information also, which will help to tailor our excision. So either we need to do more or we need to do less, depending upon So we know that medulloblastoma is the commonest tumor. So it has diverse biological behavior and has a good response to adjuvant therapy. So considering that the molecular subgroups have to be known for a simple reason that if you know that radiological classification is Wind, SSS, Group 3 or Group 4, you can tailor the excision accordingly. So here it is. If it is a Wind tumor, if it arises from the lateral recess, so here you know that you don't need to go too much. They have a good prognosis. So you know that you don't need to go too much aggressively, and you can do a safe maximal resection and not aim for total resection. For otherwise, SSS tumors, they are lateralized tumors. You know that they are mostly desmoplastic. So here on radiology, you know that this could be likely to be a Wind or SSS. For SSS, you have to go in and remove the tumor as completely as possible. Even Group 3, there is a less aggressive and a more aggressive type. So if you see that in this case also, whatever excision you do, the prognosis is not good. So in these cases also, you should do a safe maximal resection. And Group 4 tumors are large tumors which are intraventricular having hydrocephalus. Now the main crux is that the mainstay of treatment in medulloblastoma is craniospinal irradiation, the newer classification. So you have to do not a total or a near total resection, but do a safe maximal resection in cases of medulloblastoma, especially the Wind medulloblastomas. SSS, you might go and remove it completely. So the goal of treatment is obvious: to do the cytoreduction, tissue diagnosis, as well as establishing CSF pathways. So these are the questions which come to our mind always. That is that how much radical we should be? Is taking extra risk justified, or what do we do in an asymptomatic patient, or really whether the extent of surgery determines the long-term outcome in conditions where adjuvant therapies also impacts the survival. So, safe proximal tumor, the factors will again affecting the extent of surgery are this. So, you need to study the radiology very carefully. You have to see whether the vital neurovascular structures are encased, and obviously there is an infiltration. So, the pre-operative radiological assessment, for example, if you take a medulloblastoma, then if you have a CT, it will be hyperdense on CT. So, you know that this is a medullo. And obviously on MR imaging characteristics, these all things will help you to predetermine whether you are dealing with an astroependymoma or pilocytic astrocytoma. And obviously, this needs to be adhered to get an optimal therapeutic outcome. As far as possible, screening should be done, and you need to have a post-operative MR within 24 to 48 hours. Obviously, these are the problems which are very much common in our country and are challenges for surgical resection. We have large-sized tumors. They often come with blindness, secondary optic atrophy, and obviously they have an underlying cognitive or intellectual impairment. Sometimes we don't need to do anything. In these patients, it's a classical, maybe ATRT. So in this patient, the patient who is just 1 or 2 months old, maybe you will not offer treatment to this. So sometimes no treatment is also a form of treatment, and you have to counsel the patients properly. Sometimes the decisions are made by the family for having no treatment. These adjuncts to surgery are much available, and these are needed for any surgery now, especially in the posterior fossa, where you have a good preoperative radiology, microscopes, and good critical care unit and rehab. We had a detailed review of this in about 365 patients of medulloblastoma published in Pediatric Neurosciences. Most of the patients, posterior fossa tumors at our institution, we operate them immediately. So there is no question of doing a shunt preoperatively or any CSF diversion procedure. At the most, we can do an intraoperative burrow for aiding CSF drainage. Or you can, if the patient is very clinically sick or there's a gross heterogeneous, then only we resort to some form of CSF diversion. Steroids are given, and if the waiting list is too long, then you can indulge into vision or an endoscopic third ventriculostomy. Again, we do all these patients in sitting position, and because of the obvious advantages that sitting position has. And this is a classical, our air embolism rate is quite low, at least in our center, maybe because of the good anesthesia, support. And this impacts the surgical excision. So, what is the neurological condition of the patient, operation theatre facilities, waiting list, cost constraints, whether CSF diversion needs to be done or not, surgical positioning, extent of resection, sequelae and complications, and post-op MRI. The goal of surgery is obviously gross total excision, and you can sample the CSF from cisterna magna to see whether there is CSF dissemination. And obviously, limiting factors will be infiltration of the floor of fourth ventricle, as I told you, especially in the medulloblastomas, and adherence to the cerebral peduncles. This limitation is not a surgical limitation because this can be taken care of by chemoradiation. So this is what we do usually. We do an optimal bone work. We don't remove the CRs most of the times, and the same techniques which I showed in the video earlier, we do. We use the transcortical approach for lateral cerebellar, tilovelar approach for midline and CP-angle regions. Sometimes we have a superior Vermean medulloblastoma. Many times we have noticed that the medulloblastoma is in the superior portion of the vermis and presents like a pineal region tumor. And if there is a diffuse or leptomeningeal enhancement, then we do a biopsy. So this is a large tumor, which is again a medulloblastoma. You can see that most of the tumor is above the cerebellum, bordering the pineal region, and this is post-excision. You can see the arachnoid has not been disturbed. This is the quadrigeminal plate, and this is the superior surface of the cerebellum. Again, a large posterior fossa tumor, and you can see that we can do a multiple burrows. Sometimes craniotomy is advised. We normally do a craniectomy with multiple burrows, which aids in faster removal. And obviously the dura is opened, and this is what we do at the closure. So we put the bone dust. The bone dust acts like to prevent CSF leaks most of the times, and this we put the bone back. So we have not had any significant complaints of post-operative headaches or any CSF leak because we are not doing craniotomy or so and so forth. So I think this is published, and we can practice this technique if craniotomy is not to be done. Video. So this is the exposure. So the dura is open. So if the tumor is, we can use we avoid the superior vermian region usually because to prevent cerebral mutism, and the occipital sinus sometimes gives trouble. So sometimes the occipital sinus is patent in small children. Then you have to immediately evert the superior lip of the dura. Again, the same thing, release the CSF from the cisterna magna, and always when you take the transvermian incision, you go and debulk the superior portion of the tumor and never go down. Never go down near the peduncles or the medulla. So the main objective is to decompress the superior portion of whole of the tumor and release CSF from the aqueduct, taking care to see that there is no rapid egress from the aqueduct, because it can create pneumoventricle. So again, the same technique, the suction is used in the right hand and is used as a dissector and a sucker. Again, here the coagulation is minimal. Sometimes you can avoid the vermian incision and you can do a tilovelar approach. So here you can see that this is a vermis, superior vermis, inferior vermis, and you just do arachnoid dissection and expose the tumor. The tumor is almost present in between the tonsils here. And again, separate the arachnoids and go into the So here you can see that the tumor is seen in between the tonsils. Some of the speed is slow. And once you expose the tumor, then start debulking. And use that same technique. Again, go and remove the superior pole of the tumor. You can see the aqueduct. You will be able to see the aqueduct above. Remove the entire tumor. So here there is no incision on the vermis. So the same technique is used. I'll just, in the interest of time, I will go forward. You can see when the CSF starts coming, you don't have to be too aggressive about it because if to prevent pneumoventricle. So here you can see what I do, which I've not shown in the video, is that I put a gel foam and block the aqueduct. I put a small gel foam and it swells and prevents ingress of air into the influx of air into the ventricles. And you can see here, as soon as this is held by a packing, so that there is some CSF coming, but there is not enough air going inside. And after the excision of the tumor, this is what the aqueduct will see. This is just for demonstration. Normally, you did not expose the aqueduct too much. Here, usually what happens, this technique is, we just published this technique about aqueductal plugging for prevention of pneumoventricles. So here you can see that the space between roof of the fourth ventricle and the aqueduct is increased because of the tumor. And normally this is the roof of the fourth ventricle which prevents influx of air into the aqueduct. These are the cases of pneumoventricle that we have time to time. Most of them settle. Very rarely you require them to tap to a twisted craniostomy to tap the air. As I told you, superior 1 million medulloblastoma, sometimes we have to address it like a pineal region tumor. And management of hydrocephalus, we have there's a lot of literature on this. We do a CSF diversion for the hydrocephalus only if there is post-operative persistent progressive symptomatic hydrocephalus because of these problems of the shunt, which we already know in detail. And sequelae wise, we know that we have used very less retraction to prevent the cerebral mutism. Sometimes mutism can be very disabling, and it may take nearly weeks or months for the mutism to resolve. Recurrent medulloblastoma has to be taken case by case basis. So suppose it is a frank leptomeningeal dissemination with poor Karnofsky score, then you might have to resort to just palliative care, or otherwise if there is a reason symptomatic recurrence, then we can offer repeat surgery and then myeloablative therapy. Sometimes in long term you can get, because of the radiation, you can get gliosarcoma. In one patient we had a gliosarcoma which had occurred 8 years after treatment for medulloblastoma. So overall, I think the neurosurgeon has to become a neurosurgeon scientist to tailor his surgical therapy, and there has to be an awareness for molecular studies, and radical safe surgery is guided in today's era by molecular therapy. Thank you.
Next presentation is by B.S. Sharma, endoscopic surgery for interventional tumors.
Yeah, this is a 3-4 short videos of surgery of intraventricular tumors by endoscopy. And as we see that when Yeah, so now we see that we can see the tumor in the third ventricle, and we take biopsy from this, and at 3-4 places biopsy should be taken. This is the ETP being done at the same sitting, and once we do ETP, we take the endoscope in and visualize all the visual system structures, and this guarantees the completeness of the ETP. Yeah, this is one patient with colloid cyst. As we enter into the lateral ventricle, we can see the cyst. And after coagulating the cyst wall, we aspirate this thick colloid material with a tube which has a sharp needle at the ventricular end. And with gentle 20 cc syringe suction, this material is sucked. And this makes the cyst collapsing. And we see that even the foramen of Monroe has started opening up. And this was a very big cyst, lot of colloid material, and again aspiration, and now the foramen is opened up and we can see the anatomy. Now the wall is head and is cut close to its attachment in pieces. Yeah. Now this is one intraventricular tumor. Here, we use the ROSA, which is a ventricular holder, and it guides the entrance. And this is by transcallosal approach. And through the endoscopic controlled surgery, that endoscope is put through the opening, and instruments are passing by the side of the endoscope. And this is how this tumor was dissected from the surrounding brain and removed in this way. Now again, the part is dissected all around, hemostasis is performed with bipolar. And a complete excision was done. And now this is the last one, which is again a subependymal giant cell tumor. A small craniotomy and endoscope was passed, and we see this is quite vascular. So even a vascular tumor can be removed by this. And coagulating the tumor all around and reducing its vascularity, it was removed in piecemeal. So a big chunk of tumor was excised first, and then its attachment was coagulated and excised. Now this is the attachment, and this was complete excision performed. And now we can do the septum palacedotomy also in such cases, because the ventricle was asymmetrically enlarged. And then the septum palacedotomy. Thank you.
Thank you. You used a 10 millimeter sheet. So the Sharma, you use sheet 10 millimeter sheet, or you are using
as an access.
You don't use it.
Which number for endoscope? Entry into the ventricle. Which number? Which number of endoscope?
It's the standard endoscope which is used for endoscope.
No, last case to use the port sheet.
A port one, that is a thoracoscope. That is a big endoscope, and visualization is much better. Thoracoscope.
Okay, thank you very much.
Thank you.
Then next speaker is SS Kare. Surgery for covalent sinus injury.
Yeah. Good afternoon, everybody. Thank you, the organizers. Thank you, the chairman. There was some problem with the video of the cavernous sinus. So I was discussing with Kuntal And he said that, in olden times, in serious drama, there used to be a comic interlude. And many times, the comic interlude did have nothing to do with the main story. So the main story of this conference is neuro-oncology. But I'm going to show you a case which has got nothing to do with neuro-oncology. Because that video was ready and it's playing. Anyhow, so let's begin. So please humor me for the next few minutes. A 32-year-old lady who came to us and she said that she can't move her neck. Her neck is fixed like this, in this position. She had progressive neck pain and deformity for 6 years. And she just could not look up. I mean, she was stuck like this in a horrible position. These are all her pictures from every side. We tried to see her face, but you just can't see her face. Her neck was stuck like this in a horrible position. We tried to get a CT scan done, but we couldn't make head or tail of which bone is where. And we was wondering what to do. So we thought we give the CT scan images to a 3D printer guy and get a model made of the spine. So we got a model made of the spine, 3D printed model. And the 3D printed model helped us understand the deformity, but we still couldn't figure out how to fix her. We tried to put her through the O-arm, thought maybe we could do some navigation with the help of the O-arm. But her neck was fixed in such a way that she just couldn't fit into the O-arm. So the O-arm was out, and we were wondering what to do next. Then we said, okay, we have to go ahead, we have to release the neck and straighten out her neck. So the position we finally achieved was this. The patient was in a kind of a sitting position. That was the best position we could get. And that's how we operated. This was the incision which we used, and this was the exposure. The idea was to go and do a transpedicular resection of the body of the P1 vertebra, so that we avoid the vertebral artery, avoid the entry and the passage of the vertebral artery, and we get a correction. Once you remove the body of P1, then maybe we can straighten the neck. And this was what the plan was, and this was what we could achieve. You can see the cord here, you can see all the roots. And we managed to go through the pedicle into the vertebral body this way, and then you take out the body with the help of various instruments. And this was exactly what we could achieve. You can see all the 6, 7, and all the roots. And once you have this body away, then you just close the gap, and hopefully the neck, there's a horrible snap heard during the surgery, and hopefully the neck straightens out without much damage to the patient. But before you do that, because everything is completely loose, you have to have some kind of a temporary, some rod to hold the spine together. So you put in a temporary rod, fixed it loosely so that at least it shouldn't fall completely. And well, there is a short video as well. Will it play? Yes, it is. So here we are fixing the rod, and if you can see, this is the other side. People are holding the chin and the face of the patient. And the moment I say, okay, everything is ready, they're going to just lift the head up. And that's when the anterior cortex of the body is going to snap. You can hear the crack. Well, I could hear the crack in the theater. And once the head straightens up, then you complete the fixation and fix the rods on either side. A little busy slide, but finally, we did exactly that. And this was the final fixation. And if you could see, you couldn't even see her neck or her face. And even while I was closing, I think our enthusiastic anesthesiologists, they actually took a picture by putting the hand under the chin and took a picture so that the neck is straight. And well, finally we closed up, the deformity got corrected. And this was what a CT scan looked like before, and this was what it looked like later. Not a complete correction, but at least this is what we could manage. And she could at least see the world she was walking to. Thank you very much for your attention.
Thank you very much. Very interesting. Any questions?
What was the primary pathology?
Ankylosing spondylitis. Ankspon. Okay, thank you.
Okay, thank you very much.
So any sternocleidomastoid release was done?
Nothing.
Okay, next video presentation is by V.D. Sinha. Application of FedNav DEI in vestibular shoulder massage.
Good afternoon, and thanks to Sanjay for inviting me. And my topic is vestibular shoulder in surgery, the sphincter preservation. Just I will illustrate a case. A 52-year-old man presented with chief complaint of hearing loss from left side 1 year, headache, and vertigo for 6 months. Seventh nerve was intact, and Weber's test gave a lateration to the right side, and audiogram show moderate to severe sensory hearing loss. And MRI contrast showed large mass in CPA angle area on the left side, 13 by 23 millimeter with hydrocephalus. We shunted this patient, and because patient we have long waiting list. So in T2 it show good CSF covering all around this tumor. This tumor is going inside the internal auditory meters, and good CSF covering is a good prognostic factor for preservation of 7th and 8th nerve in surgery. We know that 7th nerve preservation is very important because during surgery, if it is anatomical continuity is lost, it causes devastating morbidity to the patient. Sometimes during surgery in large tumor, it is very difficult to know the position of 7th nerve. So we use the detailed images for knowing the 7th nerve position. Here, this is in LCL, this is showing the anterior, and in coronal superior, and this sagittal cuts, they are the best cuts to know the position of 7th nerve. This is the anterior and superior position of the 7th nerve. This is a small video I want to share with you, and yes, patient usually we do in supine position, helping to opposite side, cutting the dura in C shape as usual, CSF release from the cisterna magna, and after this, relax, the tumor is seen, the arachnoid is removed from the surface, and 7th nerve position is located by the monitoring system. And after, we should respect the arachnoid in this type of surgery, which is well known fact. And after localization of 7th nerve, tumor debulking is done, and we use USA for debulking the tumor. This is we are debulking the tumor. And after this, we are locating the internal auditory meters. This drilling done, and after drilling is complete, there is a small extension of the dura, which is cut, and tumor is very related. So this is very much adherent. This origin of tumor is from this place, so we should be very particular about. We should not do any stretching, or here we should do cut with the sharp instrument. So we are separating this tumor from the 7th, 8th nerve neurovascular complex, and again we are locating the 7th nerve. Intact, it is intact, and gradually in the lower kidney nerves we have put the gel foam to save the nerve, and we know that this tumor is usually adherent all around the nerves and all structure. So we always use sharp precision, scissor. This is a very just separating it with the scissor, and we could separate it nicely with sharp precision. So tumor is almost separated from the brainstem, from the surrounding nerves, and single cases we can locate the seventh nerve, what we see during surgery. Thank you.
Thank you, Viren. Now I call upon Anand to give his video presentation on use of surgical adjuncts in safe resection of gliomas.
Respected chairpersons, I'll quickly show the adjuncts that are normally used, that we use for glioma resection. We can divide them into either based on the location and based on whether there is contrast enhancement or no contrast enhancement. So multi-compartmental areas like this where you have tumor within the insular cortex, this was a recurrence, of course, partially resected elsewhere. There is a temporal component, there is an insular component, and there is opercular component. So these things we prefer to use navigation guidance. Navigation guidance by doing tumor contouring. So once the tumor contouring is done, it becomes easy to switch on the tumor contour, which gives you the exact outline of the tumor at the depth of your focus. So we can make the compartments. This is the temporal compartment, this is the insular compartment, and this is the deep ganglionic compartment. So according to the point of focus, we know which area we are resecting. Even if there is brain shift, the depth does not alter so much. Even if the depth alters, you tend to be more superficial than deep. So it is safe. And then we always verify with intraoperative imaging, so that makes it even safer. So this is good idea of giving you a directional information. It's not millimeter accurate because of the shifts, but because of the directional information you have, you can safely resect within that area that you have outlined, which it shows continuously under the microscope. So that's showing tumor resection. And even in deeper areas, when you're doing, in low-grade gliomas, if the delineation is not very clear, you can still confidently resect, knowing very well that you are resecting only the area that you have delineated as pathologic at the time of surgery, at the time of the preoperative planning. So I'll quickly show you the images. As you change the angle of the microscope, it changes, and the contour gives you a good directional information. So this is the MRI showing you the resection of the temporal completely done, the opercular area also completely done, and the deep ganglionic part, leaving behind an area along the capsule. Rest of the lesion has been safely resected. So this is a combination of navigation with the use of intraoperative imaging. Next, if it is enhancing, it becomes much easier. I'll show you some fluorescent guided resection, which we used to practice in the previous hospital. This is ALA. So this we use with the endoscope light. So whatever is fluorescing will be reddish or pinkish in color. So you can use the QSA and keep on sucking out with the QSA till you reach an area where there is no more fluorescence. But of course, this has its problems. As you can see, you cannot see any normal tissue. Bleeding, you will have to shift to white light and again do it. ALA is expensive. There could be photosensitive issues and reactions. And sometimes we do in the marginal areas where there is infiltrative disease, you tend to walk into eloquent cortex because that also tends to fluoresce because of the infiltrative region. So we have started using the yellow fluorescence more. So the yellow fluorescence here, as you can see, is much more effective. It's very clearly demarcates between the deep white matter and what is contrast enhancing. So it does not take up in the infiltrative areas. So in the deep areas, once you have resected, if I switch over to the yellow light, I get to see all the residues. Just forward it here, show the yellow light. So this is the standard resection being done. Once the standard resection is over, you get to see on resection, you see the residual part left out here, which is clearly fluorescing yellow. And all you need to do is just take them out with the QSA. And as you keep resecting it, you will see that the margin areas are nice and pinkish, and the deep white matter and the normal gray matter. Distinctly the fluorescence stops where the contrast enhancement stops. So when there is contrast enhancement and you want to resect contrast enhancing tumor, you can achieve good outcome with these. Now quickly I'll show you the other adjuncts that we use if it is near the eloquent cortex. That is mapping. We use the motor mapping and of course stimulation and speech with awake craniotomy. And these adjuncts are very useful in dissecting cases. We have already seen this yesterday in the workshop, so I won't go into the detail. I'll just show you the effect of one or two cases scans which show the effective resection. As you can see here, deep to the area is the area lighting up in functional MRI or speech area. That area has been ideally preserved and the tumor completely resected by doing awake mapping with speech. And this is for the motor area with direct stimulation showing motor evoked response. So that helps us with intraop MRI showing that there is a residual tumor here. That is also resected till we reach the motor cortex, and that's very useful. So in all the cases, we do the intraoperative MRI and intraoperative MRI with the patient moving model into the MRI. Patient is moved in a sterile, packed environment into the MRI gantry, and the MRI is done and come back. Plate is brought back and the surgery completed. So the important adjunct I would say here is not what you use, it's also the team, the anesthetist, the technician and staff who help us manage all these gadgets that you can have for effective use in the patient. Thank you for your attention.
Thank you, Anand. Now I call upon Sridhar, and he will show a video on 422 product access diagnose.
Chairperson, this is a short case of a 36-year-old lady who came with headache, a fourth ventricular lesion, which distinctly had features of thoracic access papilloma, prone position, midline suboccipital craniectomy. We always remove C1 so that we can take the dural opening below the tonsils. And that way, when we do the telovelar approach, we will be able to get to the floor of the fourth ventricle quite easily.
The projection team, is there something wrong with the videos? Becoming grainy since the last presentation.
It's looking good here. Here it is looking very bad.
Some
I think
mismatch.
the correction is.
Video is not clear.
Here it is perfect. वहाँ पर ठीक से नहीं
Everything was happening for Bala.
इमेज
ये में निकाल के दोबारा लगाओ
Yeah, thank you. So the arachnoid is cut in a linear fashion, and I keep that preserved so that that acts as a protection for my retraction of the two tonsils, and the tonsils are separated gently with a microdissector to look at the fourth ventricle and also the lesion. There you can see the lesion peeping there. And once we know where the lesion is, then we are all set to put in retractors and start our dissection. The first dissection that I do is to separate the arachnoid, which is holding the lesion, to the floor of the fourth ventricle. Once that is separated and you know where the floor of the fourth ventricle is, then it becomes much easier to start dissecting and removing the lesion. So there is the floor of the fourth ventricle under the lesion. Now the technique used here is debulking the lesion and allowing it to escape into itself. Choroid plexus papillomas being moderately vascular, coagulation is used, but not all the time. A little bit of blood keeps coming out and suck it out. But a lot of times the coagulation is used with a number 1 millimeter bipolar forceps at a lower setting, just to shrink the tumor so that more and more can be delivered into your operative field. So that is what is done here, and you will see that. So you can see tumor coming in. The video is going at a higher speed, and that's not the speed in which I operate. So biopsies are taken, and at every step, your tendency is to try to bring the tumor into the field and not just cut out the tumor. So as coagulation is done to shrink the tumor, and you try to suck some of the tumor out, whatever comes out, and then try to bring the tumor into the field with each step. Now, the first step would be to debulk as much of the tumor and pour it out of it, and not go either superiorly or to the sides, so that you're sure that you will not get into normal tissue inadvertently. So you cut out as much tumor as possible, and then start bringing the tumor down. And this is what you have to keep doing. The patient being in the prone position, one of the issues is that blood keeps pulling in, and that's one reason, that's one of the problems of doing it in the prone. In the semi-sitting, the blood would sort of drain off the field on its own, and that's an advantage of the semi-sitting. But then I'm not used to doing this in the prone because it's much easier on the arms. So tumor keeps coming into the field. You can see that, and as you can see, the tumor just keeps popping out. Now, what you have to be careful is that you don't exert too much of a pressure in bringing out these tumors. Now, that's a mix of CSF along with the blood-stained CSF which is coming out. You go into a little higher magnification to make sure that you get your dissection right, to remove the arachnoid and make sure you don't injure the ependymoma or the floor of the fourth ventricle. And that's now you have to get onto the side walls of the lesion and separate it from the side wall of the fourth ventricle, and you get out the rest of the tumor that way. And once the tumor is done, you can put Surgicel. That's the aqueduct we're seeing up there at the end of surgery. That's a good point of putting gel foam to make sure air doesn't go in, and that's at the end of surgery. Make sure hemostasis comes, and this is the postoperative CT scan. I think that's the end of it. This is the follow-up MRI, which shows a small dot there, but otherwise the patient is doing well. Thank you very much.
Thank you, Sridhar. I call Koi to talk on bifrontal approach to craniopharyngioma.
Thank you, Chairpersons. And I'm not going to talk on, the complete surgery of bifrontal approach. I'm just going to talk on only one aspect of craniopharyngeal surgery, that is the optic apparatus dissection from the tumor, or dissection of tumor from the optic apparatus. That would be the correct thing to say. And the outcome, the surgical outcome in craniopharyngeal depends on the mindset of the surgeon. If the surgeon feels that he's going to remove it completely, majority of the situations he will be able to remove it completely. But if the surgeon goes with the mindset that I'm going to take a biopsy and come out, invariably that's what will be done. So the problem comes especially in the multi-lobulated, multi-compartmental craniopharyngioma like this. And the aim over here is to appreciate the normal anatomy if it exists, appreciate the abnormal anatomy that has been created, and appreciate the pathology. And there will be reference points. The reference points will be the optic apparatus, the internal carotid arteries, and the A1s and the lamina terminalis. So these will be the reference point to which you will be coming repeatedly. And this is the incision, and one need not make a very big bifrontal flap. And and on your left hand side, you can see on your right hand side, you can see the tumor, how it looks, and the olfactory tracts have been dissected off. And thereafter, after debulking the most of the tumor from the top, now you are seeing the freeing of the optic apparatus from the tumor. And over here, I would like to point out that the tumor, as it grows, there will be fault lines made between the tumor and the normal neural tissue. So you have to appreciate what is the tumor capsule, what is the thickened arachnoid, and what are the normal neural structures. And then once you have to appreciate them, then you will be able to take a decision about sectioning a particular structure. And here you see the tumor can be peeled off the optic nerves, and here it is being separated. And in front of the optic chiasma lies a very hard calcified portion of the tumor. And this is the tumor is being separated from the optic chiasma so that the normal anatomy can be visualized, and the structures which are to be preserved get preserved. And as far as possible, we operate from the midline so that as we go laterally, and if we try to open multiple corridors, which is very often we tend to do that we open multiple corridors so that we can excise the tumor as far as possible. But mind you, in such cases, it is the perforators which are being put in the harm's way. So as far as possible, one should try to remove most of the tumors by the window what we have made, and try to coax the tumor which is lying laterally into the subchiasmatic space, and then it can be removed. And this is how the chiasma has been freed. I'll go to the next short video. Okay. So here you are seeing that the chiasma has been exposed and the tumor is being peeled off posteriorly. And then very gradually you have to gently peel off the tumor, and that will create the normal, that will show you the normal fault lines between the tumor and the chiasma, and you can see that there is practically no change in the chiasma or in the optic nerves. Thereby, there is no compromise on the vascularity, and there are no hemorrhages, and we are not losing bipolar at any point of time. So this is how the chiasma can be freed, and then we go further posteriorly, and you can see the lamina terminalis over there, which is also full of under that there is a lot of tumor material lying over there. And here, this is the tumor is being freed, and bit by bit, once it is off the optic apparatus, bit by bit can be removed, and then we concentrate on other portion of the tumor. And in this situation, one can go further further posteriorly, and open the lamina terminalis, and you will be seeing the tumor which is lying over there. And that tumor also can be decompressed, and thereafter you have to put a gentle traction in the towards the lower aspect, so that the tumor tends to open up and it gets separated very gently from the hypothalamus. And one must appreciate that you should not skeletonize the blood vessels. Avoid skeletonizing of the blood vessels. Otherwise, you'll be knocking out most of the perforator and have a very poor outcome. I think this is what I wanted to show in this short 5-minute video, that the optic apparatus will be free from craniophantom. Thank you.
Thank you, Dr. Patoi. I now call upon Dr. Dhaval Shukla to present his video on peri-rolandic lesion excised using NIM-on cortical monitoring.
Hello, good afternoon, everybody. I thank the scientific committee for accepting this video. Again, this is not neuro-oncology, but there is an OMA in this, that is a cavernoma, and resection is on the principles of any brain lesion. So purpose of this video demonstration is that when you don't have classical intraoperative stimulation tools like Ogeman stimulator, subcortical bite emitter, continuous suction, monopolar stimulation to locate the eloquent cortex and bite matter, you can use NIM monitor, what we use for facial nerve monitoring. So that was done in this case. So it was done in awake craniotomy under neural navigation and multimodal preoperative imaging. Craniotomy was done, and this is the position of the surgeon as a lesson. The surgeon is actually my resident, and the cavernoma was like it is seen on the surface. And NIM monitoring, same facial monitor was used to locate the hand motor cortex, and the good action potential was demonstrated and hand motor cortex was localized. So we know that tumor or cavernoma is posterior to the hand motor cortex, and dissection of the cavernoma was done as it is done for any intraparenchymal lesion with the same principles, like minimal or smallest possible corticotomy. And since this cavernoma was pretty big, resection was not done en bloc, but was done in piecemeal. So this is the same as, this is nothing great about this video. So gliotic plane was identified all around to know the extent of the lesion, and this is in the posterior. We know the posterior there is no motor cortex stimulation. So posteriorly the dissection was quite bold and rapid. But I will show you, the tumor was removed from all around. So now, after partial resection, in cavernomas, particularly when they present with seizures, it is mandatory to remove the hemosiderin ring to decrease the incidence of post-operative seizures and make the patient free of seizures and epilepsy. Since this was near the motor cortex, there was some reluctance in removing the hemosiderin ring. But with the stimulation, we could make out that hand motor area was anterior to the lesion, and we even chased the hemosiderin ring. Here you can see the hemosiderin ring is being removed. Now, at this moment also, again, same NIM monitoring was used, but it did not stimulate the bite emitter fibers, and patient developed right upper limb weakness. So the hemosiderin ring was not removed totally, and part of the ring was left behind, which you can see in the anterior portions of the hinge. This is the post-operative course, and this is a post-operative scan showing the hemosiderin ring abutting the hand motor area. Since he had multiple cavernomas, the post-operative screening was done. This was based on the experience of our neuroanesthesiologist who has used this technology for cortical mapping. And this is a post-operative outcome of this child. He was due for his board exams, and this is before his exam, 3 months before his exams. So you can notice some loss of dexterity in the right hand, but he is able to carry out his daily activities and was even able to write. And he did not require a writer for examination. Thank you.
Thank you, Dr. Shukla. Now call upon Dr. Batuk Diora to present the video on surgery for torcular meningioma.
person, there was a slight change in the topic. It's actually falco-tentorial meningioma rather than this thing. Good afternoon, everybody. I'm very much thankful to Dr. Sanjay Bihari and I thank him for the opportunity. So, among the all intracranial meningioma, falco-tentorial meningiomas are rare and a significant surgical challenge because of the location of the important neurovascular structure around them. I'm going to present a case of 35-year male presented with a headache and the visual disturbances for 2 months, and there was a giant meningioma involving the falco-tentorial region. This is the post-contrast CT scan imaging showing the actual location and the relation of the meningioma with the surrounding neurovascular structures. It's always an MRI that is advisable that will delineate the extent of the lesion and the relation of this important neurovascular structure. One can see the extent of the lesion in all the four directions. This is the T2-weighted images showing the both the internal cerebral vein and the galvanic vein, followed by the complete loss of signals. So we thought there was a complete obliteration of the straight sinus. So the bilateral occipital intrahemispheric approach via transtentorial and transfalcine way, we in a semi-sitting position, lesion was approached. This is the surgical video. Via intrahemispheric occipital intrahemispheric approach, lesion was reached, and the lesion was very soft, suckable, and it was hardly any vascularity. So just with the help of the sucker, it was a 3 millimeter sucker. Tumor was easily like a very soft, suckable. It was easily coming initially it was decompressed with keeping the suction inside the tumor only, and then it was extended posteriorly towards the 10 capsulator side stent that was cut later on, and one can see the extending the cut posteriorly and identifying the tumor meticulously, sucking the tumor inside the tumor capsule. One can see now near that there is a arachnoidal plane, and then the dissection was extended medially and towards anteriorly. One can see here in the midline, and maximum decompression was achieved. You can see the clear-cut CSF coming and clear arachnoid plane. At the end and on the right side, there was a significant tumor removal. And then it was approach to the fox after coagulating and cutting. The tumor was reached again, and again like with the microsurgical dissection. Microsurgical dissection technique, tumor was removed. And at that stage, I feel that I can't go on the opposite side, so I thought on going on the left side. Now again, the same principle remaining inside the tumor, gently sucking the tumor without retracting occipital lobe, and doing the microsurgical dissection. Now one can see here the anterior-most portion of the tumor from the parenchymal plane separating the arachnoid and dissecting the tumor. Again, one can see here there is a clear-cut plane was there that was slowly dissected out and lifted up. This is the posterior extent of the tumor towards the tent, and one can see that there was a clear-cut CSF coming down. And again, like the same principle, slowly and steadily, gently, tumor was deworked and the vessels in the quadrigeminal assistance were identified. The last part of the tumor that I thought was like in the region of the venous system, that was like after coagulating and cutting the part of the fox. Finally, the venous system was seen. One can see here that there was I thought it was a very galvanic venous system, and the part of the tumor around that was left. Post-operatively, patient did well. And this is the post-operative CT scan without any neurological deficit. Report was transitional meningioma grade 1. Patient was discharged on the 7th day. Before the discharge, we have done the MRI. This is the flare images. This is the post-contrast imaging in the axial and the sagittal. There was small remnant. This is the 1 year and 8 months follow-up of the patient. There was significant removal of the tumor, and I mentioned like the part of the tumor that was in relation with the venous structure that was left. This is in the axial plane, this is the sagittal plane, this is the coronal plane, and this is the patient working happily in the farm. Thank you.
Thank you very much. I now call upon the last speaker of this session, Dr. Mandeep, to present his video on surgery for cerebellar hemangioblastoma.
Good afternoon, ladies and gentlemen. I bring you greetings from the Army Hospital Research and Referral from New Delhi. And I would like to thank the organizers for giving us a chance to share our work with you. In addition to the surgical video, I would like to share the travails of our patient over a 14-year-old clinical journey and our surgical concerns in managing. He came to us about a couple of months back with difficulty in walking and speech changes and neck pain for the last 4 to 5 days. On examination, he had severe ataxia with cerebellar signs. He had a long history wherein he had undergone a VP shunt in 2006. There were no documents at that time. The earliest radiology we had was a DSA from 2007, which showed us hemangioblastoma about 2 centimeters in diameter. He underwent a couple of procedures in November and December 2007 for this hemangioblastoma. Thereafter, his travails began in a long journey. Follow-up MRI in 2008, nothing significant on the operated side as shown by the green circle. Something started cropping up on the opposite side as shown by the red circle. 9 years, this had grown significantly, but he was kept on follow-up. 2018, significant increase, still kept on follow-up. And by the time he presented to us, this is an MRI of 2019 November, this was the situation. You can see the significant increase of the lesion. Since the setting was of VHL, the MRI spine showed multiple lesions. The CCT abdomen, pancreas, started cysts, bilateral renal cysts, retinoscopy showed a peripheral vascular tumor. And we had on our hands a large 5 into 4 into 3 centimeter multiple hemangioblastoma with multiple small hemangioblastomas. The clinical setting was that of impending tonsillar herniation, and we could not offer him any more follow-up. He had to be operated upon. We did a DSA which confirmed a hypervascular solid core of about 5 into 4 centimeter hemangioblastoma nidus. The principle of hemangioblastoma remains an en bloc excision with perilesional dissection. They say if you stay out of tumor, you're likely to stay out of tumor. If you go into it, it's likely to bleed. This may be okay with classical tumors which have the neural nodules varying from 1 to 2 centimeters, but in our situation, with something like this, a large 5 centimeter lesion in a tight posterior fossa, would it be possible? There was only one way to find out, so we took him up for surgery. He had an existing left-sided retromastoid suboccipital craniectomy, but our lesion was more on the opposite side coming to the midline. So should we do a right RMSO, a right paramedian, or a midline suboccipital? So we operated upon him in a prone position and extended the craniotomy with the midline suboccipital craniotomy, and this is the operative video. Just to orient the audience, this is the right side or the lateral part of the lesion, superior, the left side of the patient or the medial part of the lesion, and the inferior. This is the hemangioblastoma as is outlined. We had decided that we would try and take it out en bloc, going all around it. We knew it was going to be a problem because of the size of the lesion. Retraction would be a problem, but if based on the DSA, we thought if we entered it, it might be a catastrophic bleeding. So this is the right side superior part being dissected. This is the left of the medial side. At some places, there was not much vascularity and we could work on the gliatic plane as can be seen here. But the bleeding kept on happening, and the problem with retracting it was a very turgid lesion. And as it would kind of press onto the lesion, it would either start bleeding from where the pressure was there. This is the part which is being operated. So it either starts bleeding from where the pressure is put, Or as you would see, it sometimes would start bleeding from the opposite side, something like a contour 2 kind of thing, because here you can see. So there was significant bleeding throughout the surgery, as was expected. With some kind of patients, we kept at it. This is the bleeding being controlled. This is the left superior part of the lesion being tackled here, left side superior part. You can see the significant bleeding. And we kept working all around it. The cotton patty kind of helped in dissipating the pressure so that it would not burst from one part where the instrument would kind of press on it. Wherever there were small vessels we could see, we could coagulate them. Otherwise, more or less surface coagulation with low settings to kind of bleeding was troublesome. Now we shifted to the other side, went on to the superior and right side of the lesion. This is the other side of the lesion. You can see the tent here. Again, you'll see that you can see the vascularity, so no wonder it was bleeding. This is the tent, and this is probably the last part of the attachment of the tumor, which we are kind of tackling right now. So finally, without grossly entering into the tumor, there were some kind of transgressions in some places, but after about some hours of struggling and about a lot of blood loss later, we could take it out whole, about 5.5 centimeter tumor. The cut section shows that it was totally solid. The histopath showed classical features of angioblastoma. The post-op MRI shows complete excision of the lesion. The DSA shows that the big lesion is totally out. You can see the pre-op and the post-op pictures. And the patient did well and is recovering well now from surgery. Thank you.
Thank you so much. On behalf of my co-chairpersons, I thank you all for being here. Thank you.
I request chairperson to please be seated for the felicitation. Thank you, chairpersons and speakers, for this wonderful session. We have certainly learned a lot from your presentations and your shared experiences. Now I request Dr. Kiyoshi Saito to please come on stage for felicitating Dr. R.C. Mishra and Dr. Dattatreya Majumdar. I request Dr. Deepu Banerjee sir to please come on stage to felicitate Dr. B.S. Sharma and Dr. S.S. Kali. Thank you, sir. Now I request Dr. S.S. Kali. Now I request Dr. Manish Gill sir to please felicitate Dr. H.S. Batoy and Dr. Dhaval Shukla. Dr. Dhaval Shukla sir. Dhaval Shukla sir. Manish sir. Now I request Dr. Varnan Velu sir to please felicitate Dr. V.D. Sinha sir. Now I request Dr. K. Sridhar sir to please felicitate Dr. Batuk Devra and Dr. Manish Gill sir. Thank you, chairpersons and speakers. Now we head to our next session on deep neuraxial tumors. I would like to request our chairpersons to come on stage, Dr. H.S. Badoy, Dr. Dhaval Shukla, and Dr. Tarun Pandey.
Yeah. I'm so looking forward to it. And who's the chair? He was here last time. He was here? Yeah, BCM Prasad? He got chair recently. Oh my God. BCM Prasad is the chair. He's an immense guy.
Good evening, everyone. And as we come to the end of today's deliberations, I think this is the last session. And what a session it's going to be. Sorry, correction. This is the second last session. So, and it's a privilege to be seated here and to listen to the stalwarts led by no less than Professor Anil Nanda. And of course, he needs no introduction. So straight away, I'll request Dr. Anil Nanda to come and deliver his talk on brainstem tumors, surgery for brainstem tumors.
Thank you, moderator. Thank you so much. I thought by the time I give my third talk, you'd be completely fed up with me, so I'm happy. Let me just see. This is who's working this now? How about that? It was working. We very tough. So hard. अभी चल रहा था जस्ट when you switch to it दूसरे बैग ये तो नहीं चल रहा था मॉर्निंग इंडिया में ये पहले वाले चल रहा था मैं अपने sorry again. Some different approaches. Jai Ho Bajrang Bali. Good, thank you. So I'll go quickly through this. Just to give you some approaches, if you go subtemporally, this is how you can approach the brainstem with a petrosectomy. If you want to the retrosigmoid, those are the safe zones between the trigeminal nerve and 7th and 8th cranial nerve. Just the far lateral approach, if you come a little lower, and this is the retrolabyrinthine approach, and of course the midline. So I'll show you one of each of these. This is the OZ approach, if you come from the front, and the supracerebellar infratemporal approach that Danielle was talking about. This is the extreme lateral supracerebellar. So this is a brainstem cavanoma in a young girl. Just to show you the video on this. So I use a stealth to map this. This is a pure retromastode. I'm using the stealth right there, making a small opening. I should have used a phaco knife on this, man. I just learned. You can see that. So these are always a few tense moments when you open the brain stem and you're not certain if you're going to hit anything. So, and then once you see this, then you're like, okay, I can breathe. I don't have to have any apneic spells. But here you can see we are taking this out well. Once you hit the clot, the cav is relatively easier. Here it has got multiple fragments. I have about 45 brainstem cav that I've removed, and I can tell you that I've had at least 2 recurrences. So I'm extremely cautious to try and get every piece off the cav and not to say, oh, we'll wing this. So you can see here, got a nice plane, but I'd like to take the entire thing off. And I'd rather be aggressive than come back with a recurrence, you know. It's a pretty large, 17-year-old girl. She was hemiparetic, and the other neurosurgeon didn't want to take it out, and I wasn't keen either. But the family said, "Well, you know, she's 17. We don't want her to live like this." So we decided to take this out. You can see it's a nice plane, big clot there. We removed everything. And I think the only learning lesson for the residents is that if you should get into the clot and then go around it really carefully and take your time. Don't just say, oh, we got a little piece and we're done. Make sure you get everything out. You see a nice white gliotic plane because recurrence, I've been burnt on recurrence. So you'll see something and then a year later it comes back, even though your MRI was okay. And I love putting flow seal into that cavity. So she did well. This is another one like that. Oops, sorry. Yeah, there it is. Similar thing. In this one, we were a little more worried because, again, I used the stealth, try and get exact localization. 7th and 8th, retromastoid. This is the superior part. And this one was a little, and I really didn't hit blood. So I kind of got, and it's the worst place to get lost is in the brain stem, okay? This is never good for your myocardium, but here then finally we got into the clot and we were able to get this out. Once you get into it, it's not that bad. My only teaching point is that be a little patient, take every little piece out, every little nook. And here we were able to do that. I love the retromastoid approach. That the entry zone of the brainstem is just below the trigeminal nerve. That works very well. You don't want to touch the 7th and 8th cranial nerve, which you can see lower right there. 7th, 8th here, trigeminal. So this is a nice corridor to enter the brainstem right there. And this is the cav still there. Little big piece still, I think, existing there. So here's another cav that you can see here. This is posteriorly, and this is a good approach through the suboccipital approach. And so if you retract the ring, this is superior, this is inferior, and you really don't need the stealth. You can actually see the red thing there. And once you're in the clot, this had bled twice. Once you're in the clot, it's easy. The problem is, you say, oh, you want to avoid the facial, you monitor the facial. The thing is, you have to go right into the clot. And I was worried about the facial nerve on him. We actually just got this published in World Neurosurgery. Whose impact factor is less than neurology. But you can see that. So we're in it. We got the whole thing out. But as easy as this looks and you feel really good, he had what's called an 8.5 syndrome. He had a facial nerve weakness, and then he had some medial visual, because this is going a little faster, it's not the speed we did it at. And we were to get the whole thing out. This is his picture, but he did have a facial nerve paresis, and we got a complete resection on him. He's actually improved a lot. Here's somebody with a calf mal that was operated on by someone else, and then re-hemorrhaged here. So we went back through the same approach. Again, same retromastoid approach. Actually, I'll stop. So I want to do the last case. I want to show you. We weren't sure the diagnosis on this. We weren't sure the infection. We weren't really certain. So I showed this in the earlier talk. This turned out to be a metastatic tumor, but it's a nice case to show. It's an older videotape, so it kind of shudders a little bit. The cerebellum there. I'd like to clear up all the arachnoid there. This is the one thing I learned from Janetta. He was very, very meticulous on clearing up all the arachnoid stuff, so you don't retract as much. And this retractor is really not pulling that much, just sort of keeps it out of the way a little bit. And again, I think the stealth is very useful for this, just to get a better idea. Sharp dissection. I agree with Manuel. There's nothing like a sharp scissor. Straight sharp scissor. I only use that. Just clear it up completely there. Now, this turned out to be a metastatic tumor, so you could say, the life survival is not good. Why do you really need to do this? I think we did it partially with diagnosis, and he was kind of compromised neurologically. So I felt maybe if we decompress that would be better. So here now you can see we got it. We were worried this was an infection, so the whitish fluid came out. And I thought, well, this could be a brain abscess. And here we're now in this suctioning out this brainstem lesion, of course, the intraoperative monitoring. And initially I was happy. I said, well, it's an abscess, he should do well. But this turned out to be metastatic. You can see we cleaned them out quite significantly. Everybody has their favorite instrument. I love the 60-degree dissector. I use that a lot. So we didn't want to go for broke, but we cleaned it all out pretty nicely. Kind of moving a little bit of older tape. This to show you the entry point and the resection there. And that's it. Thank you so much.
Thank you, Dr. Nanda. Any questions for Dr. Nanda on brainstem lesions? Okay, then I call the next speaker, Dr. Mohindra, who will be speaking on the retromastered approach for CPM tumors.
Good evening, ladies and gentlemen. Greetings from the city beautiful, Chandigarh. I'll be
continuing with the same topic, CP angle approach to the retrosigmoid approach to the CP angle neoplasms. I'll be focusing more on the basics of acoustic humor surgery and more towards the people who are trying to enter into this era in the world of CP angle approaches or basic acoustic humor surgery. So this is the schematic diagram. This is a diagrammatic representation of how the tumor forms. This is the normal nerves formation of the tumor, and then slowly it enlarges this way, causing a double layer of the arachnoid over the tumor. This is a classical acoustic tumor, right-sided CP angle tumor. T1 contrast enhancing, T2 hyperintense signal, T1 without contrast, no enhancement. Classical CT scan, widening of the porus acousticus, and this is the coronal section. So this is the way we do it. We position the patient. This is our way. We do it in a supine position. The angulation at 45 degree. Temporal squama is flat to the this clamps the floor, and we rotate it at 45 degree. This is the angle of the shoulders are at 45 degree to the base, and then further 45 degree the head is. So that is the way we make it. It's an RMSO approach to the CP angle. This is the head-on picture, and this is the lateral picture. See the angulation, how 150 degree this angle is there, 45 and 30 degree angle is there. This is the standard technique which is used in PGI Chandigarh, and all our surgeons are using this approach only. Most of the surgeons are using this approach in most of the cases, and everybody is comfortable with it, including anesthetists as well as our residents, trainee, fellows. They all make this position and start the surgery in this position. So this is the pictorial representation. Sorry for the video which is not playing. I just want to show the exact position which has been made so that it can be copied, and we can all practice this. This is the supine position in which this supine with the head down with the two sandbags are placed.
I think we can skip the video if you can proceed further.
None of the videos are playing.
None of the videos.
Manju? I'll just get it.
We'll request Dr. Sandeep Mahindra to his talk can be had after the next speaker. So now I can invite Professor Kyoshi Sato to talk on tribal chordoma, how to make difficult ones simpler. Professor Sato, please.
Okay. Now, surgery for private chordoma is wide exposure or endoscopic removal. Our results showing that the overall survival rate, 15 years, 10 years, 15 years, about 72%. But if tumor extended beyond the pier, under the pier to the brainstem, I mean, this is brainstem tumor extension means that tumor extended sub-pier to the brainstem, then we can control it. Otherwise, our result is very good. So standard treatment for chordoma is resection, maximum resection plus high-dose radiation. To improve tumor control, to prevent recurrence. But my question is, why tumor removal difficult or why recurrence? Then I thought that because the chordoma located in a deep location and the chordoma invaded to surrounding bone, and then we had intraoperative feeding. So for deep location, first, we did scalpel surgery for wide exposure. But nowadays, using endoscope, we can reach to the deep location. For invasion to the surrounding bone, we need to drill out or remove surrounding bone. I don't know how we can prevent intraoperative seeding because we can't remove envelope. So this is my favorite approach, anterocranial facial approach for wide exposure of the brainstem. To preserve olfactory function, we cut the nasal cavity under about 1 centimeter under the plate. For that, we need to remove nasal bone like this. This is a case of the 49-year-old female. Probably I showed this video before, but we did exposure of the nasal bone and by frontal craniotomy, and then we cut the we made a osteotomy using reciprocal saw like this, or we cut nasal bone, orbit. After that, we made a osteotomy around the cruciform plate. Then we remove the piece. We call it orbital nasogranular bone. Then we cut nasal cavity about 1 centimeter below the cruciform plate. So we can preserve olfactory function here. Then after removal of the tumor, to keep the nasal cavity open, we put the Sarascon tube into the nasal cavity. Then everything return to the position. We need to reposition the medical canthal ligament, and then everything in position. So this is post-op. And also we publish the data of olfactory recovery like this. So this is another patient, young patient. Then we removed using this approach. I cut the pituitary gland in the middle to reach the posterior part of the pituitary gland here. And then I meticulously remove everything, excuse me, all the tumor and all the bone. And here is the defect by the tumor in the crevice, and I put the fascia in the hip. And then, as I explained in the previous presentation, we used bipedicle temporal parietal area flap to reconstruct the skull base. And we put this end anchored to the end of the crevice. This chordoma, I selected 3-stage surgery: right transcondylar, left transcondylar, and transoral. And for this tumor, I selected combined petrosal. Mainly, this tumor located in outside of the dura, but this part destroys the dura. And here, tumor extended into the cavernous sinus. So I selected right combined petrosal approach. Again, I remove tumor meticulously. Then I remove the tumor extended to the cavernous sinus until we had a venous bleeding from cavernous sinus. And then finally I drilled crevice as much as possible. So this is post-op. This is another patient, tumor extended down to the crevice. For this patient, I selected orbital diagnostic approach. Then we expose the cavernous sinus and cut the cavernous sinus to reach the middle side of the cavernous sinus. This is V3, V2 spheroidal feature. And carotid artery scrutinized here. This is cochlea. And crevice bone, crevice dura we can see here. And I removed it. Then the skull base is reconstructed using temporal parietal area flap. So this is post-op. But this patient, after 17 years, referred to us again with this recurrence, bilateral recurrence. So for this, we decided stage surgery. First surgery, we used left diagnostic and left transmastoid to remove this part. And then second stage, we selected right transmastoid and transnasal approach to remove this part. And this is post-op. This patient had a heavy particle treatment after this surgery. But now, most of the chordoma can be removed using N-nasal endoscopic approach. This is recurrent chordoma, and my colleague removed this using an N-nasal endoscopic approach. So this is left optic nerve here, and he removed the clavicle bone as much as possible. Very orbit, and eyeball, nasal ara. He removed as much as possible. So this is post-op, but this patient had a recurrence after this, and we operated 2 more times, and then we stopped surgery. This is another patient, not big tumor, but extended intraorally and extended here behind the carotid artery. So this is Watanabe operating. This is carotid artery. Here is the defect by the tumor. And now we are removing the tumor behind the carotid artery. Here is the dural canal. Abducent now run somewhere here. And I'm saying that remove everything. So he is now removing this part. So abducent now is partly damaged, but later his abducent now partially recovered. And this part was covered by fascia and now the septal flap. So this is abducent now, the Rhodes canal, and we'll see interdural abducent nerve here. So this is post-op. So now make surgery simpler. I prefer skull-based surgeries, but now my young generations use end-nasal endoscopic end-nasal endoscopic approach to reach deep skull-based region. But still, we need to drill or remove surrounding bone because tumor extended into the surrounding bone. So again, I will have the 15th Asian Oceanian International Congress on Skull-based Surgery in June 11th to 13th in Fukushima. We have a main theme is skull-based surgery, the next generation. So this meeting is for young surgeons in Asia, Oceania. So we had symptoms, symposiums, and special lecture by Anil Nanda, Tata Giva, and Fernandez Miranda. And also we had a hands-on demonstration of exoscope and the education course for the young doctors. This is Fukushima. Fukushima is a beautiful place. And here's Sanjay and Suresh Naik visited us. I forgot, maybe 5 to 6 years ago. But anyway, Fukushima is a beautiful place. So please come to attend this International Skull-Based Congress. Thank you very much.
Let's go number.
Thank you, Dr. Santo. Do you have any questions? So we call again Dr. Mohindra to talk on Rectomaster approach for CPN.
So continuing my talk, retrosigmoid approach to acoustic humors. This is the diagrammatic representation of the humor which I have already described. This is the classical presentation of acoustic humor, right-sided. This is the position which I described in detail according to the angles, how we make it so that a supine position can be utilized for the excision of acoustic humor, which makes our residents, assistants, fellows, nursing staff, as well as the anesthetist much more comfortable with this position. This is the position, pictorial representation, and this is the video taken from around the patient, how the patient is fixed up. Two sandbags have been placed over there to make this shoulder angle, interblade angle at 45 degree with the floor, and this temporoschema is flat with the floor. This is the craniotomy. We routinely make craniotomy for all posterior fossa cases. This is the exposure. This is the caudal end. This is the cranial end. Retrosigmoid approach with the digastric groove quite clearly visible. This is mastoid, and this is self-retaining retractor. And how the craniotomy has been made single barrel. Midas high-speed drill is utilized, just abutting the mastoid. This one, and the craniotomy is made. Dural oblique. This is the sigmoid sinus. This is the transverse sinus through a single barrel. Craniotomy has been made, and then we tailor the lead of dural exposure according to the exposure of the transverse and sigmoid sinuses. This is a routine. This is the basic teaching to the junior faculty as well as the training residents that both the sinuses should be well exposed and the emissionary vein should be coagulated under vision. Most of the times the air cells will get exposed, they are to be vexed. This is the durotomy which has been made, single linear incision to expose to the durotomy, and then a T-shaped incision right in against the sigmoid sinus. Now, these routinely will find the cerebellum just underneath the dura, and this is the way this cerebellar retractor has to be placed to release the CSF. This picture has been given to the book also, which we saw the release today morning. This is the retraction. This is 45 degree. This is not like this retraction. This is 45 degree. Neither cranial not this way, but this 45 degree obliquely from the skull base to release the CSF. This is the external ventricular drain which has been placed in this particular case. Not routinely we place. The shunt is there. We do not place it. And this is the release of CSF at the skull base after placing the retractor under microscope. CSF is released fully. Lower cranial nerves will start getting visualized, and this is a large acoustic humor with cerebellum just overneath it, making a layer of. This is the cerebellar lower tonsil hanging over the cerebellar tumor. This is the acoustic humor. Gradually, the tumor will start coming into the field on its own when the CSF is released, and the utilization of gravity, that cerebellum will fall off. This is the tumor surface is visualized under full magnification of microscope, and then after cleaning of the arachnoid, these small vessels are coagulated, and the entry point in the acoustic schwannoma is made. While after just making a nick, slight coagulation over the tumor surface, after peeling of the arachnoid, we enter into the tumor. The basic principle remains the same: to decompress the tumor intratumorally with a CUSA to decrease the amount as much as possible for the cerebellum to fall off and to make the surrounding structures, which are most vital structures, to come into the surface into the vision on their own. We are using curette in this case. This is the usage of curette just to check. Once we enter the tumor with a curette, we come to know the amount, the vascularity of the tumor. The delivery of the lower bone is the primemost first step. After releasing the CSF, the tumor lower bone should be delivered till we see the lower cranial clearly, pica as well as the brainstem. The tumor is debulked. Just see, the moment we are debulking the tumor vigorously, the cerebellum will keep on falling off. We'll see the cerebellar retractor, this one, remaining stationary within the air without compressing the cerebellum, and the cerebellum will fall off. See, the cerebellum is itself giving way, and the tumor is getting visualized, and the lower cranial nerves are now clearly off the tumor. Just with a sharp dissection with the microforceps, they are released as such. We leave them hanging at the lower bone, and we use CUSA over here to debulk it further. Debulking of the tumor takes the most important step, is the most precedence over it, that the debulking should be as much as possible so that the tumor remains as such a empty envelope. Now the usage of CUSA. We can use the CUSA to make another hole to bring the tumor more under visualization and into the field. Just see, the tumor has been debulked from the top end also, and has been visualized and has been brought into the field. Now see the peeling of the arachnoid. This is the tumor which is coming away from the cerebellum. We are peeling it off. Cerebellar surface is being left behind, and this arachnoid is being peeled off from the tumor. Now we are gradually moving towards the medial edge of the tumor, which was invaginated within the cerebellum surface, and towards the superior bone. Now we are using CUSA again. The tumor is now then lifted up with the tumor forceps, and the arachnoid along the cerebellar surface is left towards the cerebellum. All the vascular structures and the arachnoid is to be left towards cerebellum. Only the tumor tissue is to be taken out and away towards lateral direction. Coagulation I use quite a little, but this is at the meatus edge where the dura is being coagulated and the meatus is being visualized now. This is the dura. This one is the dura. Now this one is the tumor which has been left entering into the internal acoustic meatus. Now the drilling of the internal acoustic meatus, we do it on the superior edge, and within the radiology we should always be aware of the high jugular bulb. This is the way the meatus has been drilled. But while drilling the meatus, we keep on looking below that the tumor and the meatus is getting visualized, and the intramedullary tumor is clearly seen. After that, smallest curette is utilized to deliver the tumor out of the meatus and to come into the field, and a CUSA, which is of the smaller size, should be utilized to just get the tumor out of the meatus. After clearing the meatus, again the CUSA is utilized so that the pull on the facial nerve is not there. Most of the times the facial nerve which gets damaged is at the angulation of the meatus, just at the exit from the meatus. That is the place where the facial nerve gets damaged. This is the last picture which we can see of the after the tumor has been excised. I'll just show you the labels. This is the complete excision of the tumor. This is the cranial end, caudal end. This is the 6th, 7th lower cranial nerves. And the 5th nerve is also visible. I'll show you the next picture. Now you see. 6th, 7th, and the lower cranial nerves and the brainstem. This one is the 5th. So retrosigmoid approach to the schwannomas, it has been long described. It remains the most challenging surgery because of the intricacies and the small narrow corridor which is there for the tumor to be negotiated out, and it remains the benchmark of neurosurgery, and the intricacies and the final movements are tested only in this kind of surgery. So I would just show the pictures which were taken during this surgery. This is the release of CSF from the cerebromedullary system and peeling of the arachnoid, debulking of tumor with CUSA, lifting of the lower pole from the lower cranial nerves, and this is the dissection from the upper pole, 5th nerve, petrosal vein, lifting of the tumor from the cerebellar surface, posterior superior lip of the internal acoustic meatus is drilled off, and this is the drilling usage of the blunt hook, delivery of the tumor from the middle area, and the residual tumor which is sometimes left behind to safeguard the facial nerve. Tumor cavity after dissection of the tumor. This is another picture in which small amount of tumor has been left along the 7th nerve. Fixation of the bone. We routinely fix the bone with craniophix. This is the applicator, and these are the craniophix which we use for craniotomy fixation, which helps us in preventing pseudomycoses. And this one is I have already shown. This is another video. Just to come out of CP angle tumors like acoustic schwannoma. This is another tumor which we had encountered in our practice, in my surgical practice. Just watch this. This is the radiology. This case I am showing just to highlight that once we are quite acclimatized with the retrosigmoid approach to the acoustic tumors and we enter into the surgical operation theater with prefixed mindset, and we open up RMSO approach for the similar kind of acoustic tumor, and we just do craniotomy and find what next. Neurotomy is being performed as I have told earlier, and you see this is a large coulter-shaped type lesion sitting in the cerebello-pontine stern. Lower pole is being lifted up, cerebellar retractors are applied, and we find a dark coulter-like lesion, sticky and highly vascular. Sometimes these surprises do come with us while managing routine acoustic schwannomas. This radiology was almost similar looking with the acoustic tumor, and we found out this kind of lesion in the CT angle system. And it was quite of a size, more than 5 centimeters in CT angle system. The patient presenting only with gait ataxia and cerebellar symptoms and hydrocephalus. So we had, in this case, we used both curex, CUSA, but none was effective, and finally we had to take a punch. This is tumor forceps being used. I don't know any of the audience has ever seen such a lesion in the CT angle.
I have seen. I don't know, I have seen. Even
this is the punch. Finally, we got hold of this tumor only with a punch, because that was the only way left. after this surgery, we realized that melanoma is quite tricky. It's quite vascular, and it doesn't come into the CUSA, curex, anything. It bleeds a lot. Surface supratentorial melanomas behave not the way it behaves. I think they're not that much of vascular the way it behaves. Contrary to the meningiomas, which are supratentorial, more vascular as compared to the posterior fossas. The complete Polta type sticky lesion, jelly type, but formation between. So finally, this tumor was lifted up completely. As we are visualizing only this tumor and tumor surface only, then none of the cranial nerves were visible till the whole tumor had come out.
Dr. Sandeep, would you like to
Yes,
conclude?
yes. I'll just show the last picture of this scan, this surgery only. This is the whole tumor comes out and the hemostasis is achieved. And this is the hemostatic picture. Patient did well. This is the post-operative CT. Thank you very much.
Thank you. And now we have the last speaker of the session. Surgery for foramen magnum tumors, Dr. Manuel.
Not last, one more person in there.
I was given a list of 4 speakers. Dr. Manuel, please.
Okay, here we are again. Everybody's sleepy by now. I'm tired. I'll try to keep it simple. I've changed the subject. It's surgery for foramen magnum meningiomas. Otherwise, we would be here forever. So, the point being that we often enough, it's good that we have new approaches, more aggressive approaches, especially skull-based approaches. But I think, yeah, I know. But I think sometimes we proceed on to moving to more complicated, more ablative approaches without making full use of more conventional ones. Still thinking? Yeah, right. Okay, so foramen magnum meningiomas, you have to be knowledgeable about the anatomy, the boundaries of the foramen magnum, both from the outside. As for the inside, the strict correlation with the both condyles and the hypoglossal canal, and I'll just speed this so that we can get to the videos. And of course, the outer anatomy, and the inner anatomy, what's inside. And this is particularly important because the most tricky part of getting an adequate exposure for foramen magnum meningiomas is the anatomy of the vertebral artery. Biggest concern, if they're posterior, there's no big issue, you just come posteriorly and take it off. If it's lateral, you have, nobody will argue that a normal lateral, posterolateral approach would be good enough. The question is raised when it's anteriorly also, whether should we go to a extreme lateral,
because I'll be using the name far lateral as a synonymous for postural lateral, which is the nomenclature used by Bernard Georges. And it's my point is that you don't, well, at least I've never had the need to use an extreme lateral. I've always used a postural lateral for anteriorly based tumors. The only reason that I see for going more extreme is that if the tumor is not intradural, but it's in the bone itself, and then we're treating a disease, which is the disease of the bone. If it's intradural, the meningiomas will make their way, they create their own space, so you can always find a way in. And the anatomy is vital, especially the V3 segment of the vertebral artery, as it switches from being vertical from C1, from C2 to C1, and then on laying on the upper arch of C1 into the dural ring. This dural ring is somewhat different from the carotid because it's much more adherent to the subperiosteal layer, to the outer layer of the vertebral sheath. So it's at times preferable to leave a little cuff other than running the risk of sacrificing, of poking a hole in the carotid. So the anatomy is vital. You have to pay attention to of course, the cranial nerves. You have cervical nerves, C2, C1. C1 also is traversed by the posterior spinal artery, which rises at the dural ring, most of the times outside, extradural, whereas this anterior spinal artery is initiated intradurally. And then you have the rootlets coming up from the spinal cord, which are going to form the biggest part of 11, along with some anastomosis with C1, and then you have the rootlets for 12, and then again the lower cranial nerves. The cord is maintained in its position by the dentate ligament, which is crucial to cut so that we can free and use the space freely to identify the anatomy and work. These tumors can grow ventral or dorsal to the vertebral artery. They can grow inferior or superior to vertebral artery, thus causing different displacement of the cranial nerves. If it's all ventral, then the nerves will be all splayed out in the back. Whereas if it's anterior, it will be intermingled, and these tumors often have enough lobules to make our lives miserable when dissecting, especially when they extend up to the jugular foramen. So, of course, the anatomy vital. Again, you see the rootlets, you see the V3 segment, you see the spinal artery, you see that the cord roots of 11. And this is vital to expose the anatomy. To expose the vertebral, you will see it on the by extradural. You have to watch out for the venous plexus, which causes a lot of bleeding. You should just pack it, and then you can compare the entrance point extradural and intradural, and that will lead you to where the position of the vertebral is when it's covered by the tumor, as I will be showing you. So some nice pictures of the anatomy. It's always good to go back to the atlases, go back to the lab, check it out before you actually start doing these cases. Not that the procedure, this is very nice here, as you can see that the relationship of the vertebral artery, the lower upper cranial nerve, C2, C1 here, and then on to 12, and this is 11 and 12 there. Again, the posterior anatomy is much easier. You'll have the splayed loops of pica to deal with, but this is all old news. So I will just show you a couple of examples of how I use this. Of course, the venous plexi are important to deal with. This is what I told you about. It always bleeds. You should just pack it, and then you'll verify where the vertebral artery lies and be able to localize it also intradurally. We usually take it. This is in one single flap, inferior to the occipital protuberance, and just cut the muscle and take it all in one piece. This is a case of a woman who came in. She was having trouble with her gait. This was her tumor. Again, pretty sizable. It's bigger, but it's pretty sizable. It's lateral, but it's also anterior. And we, And we used again a posterolateral approach without even. We took as much as of the foramen magnum rim, but not getting into the condyle. The patient is carefully positioned. This is crucial. It's sort of a semi-lateral concord where you expose this whole retromastoid upper cervical area without giving it too much flexion, especially for bigger tumors. What's happening here? And in this case, you open up the arachnoid, localize the nerves. As you see, we knew that we checked on the outside, the vertebral artery was coming up here, was extradurally here. We are using the Cavitron to localize it because it's somewhere among those lobules of tumor. So you have to carefully proceed. Once you've verified where your vertebral artery is, you can take a piece from below the vertebral artery. Here it is. You see the vertebral artery right there. So we freed up the component which lies below. As you see, we can go fairly anteriorly because the tumor is just splaying it out for us. And then you go above the vertebral artery, which you see being manipulated there. So you skeletonize the artery. But it's not over yet because the tumor extends up above into the lower CP angle and to the foramen, into the jugular foramen, and you have to. And these rootlets of 12 and the lower cranial nerves are going to have to be found among the lobules. So it's not that the tumor grows only ventral or dorsal; it grows both ventral and dorsal, and you have to proceed trying to localize these nerves, sparing them. Even if surgery runs beautiful, there will always be a deficit, at least changing from manipulation. These nerves are not made to be looked at, let alone fussing around with them. So to say that these patients come out bright-eyed and bushy-tailed, it's not true. They look pretty good, but when you start talking to them, they have dysphonia, they have trouble swallowing. You have to give them some time, even when the nerves have been preserved. And then the function will gradually come back. Right, so this is it. You get proceeding. You can see how ventral you can go. You can go ventral. And once you've taken out the main part of the tumor, then you have your time and you have the whole space of the world. You can get across to the other side. There's really no need, at least in my mind, to use more of an exposure, especially a bony exposure. So, cut the story short, so you end up with the tumor. You see the vertebral artery being skeletonized. You're above, you're ventral to the vertebral. You go all around it, and you've taken the tumor out. This is how it looked afterwards. She did fairly well, despite the fact that she had those weeks of training for swallowing problems. Again, another one, quite ventral, you'd say. It's also lateral, it's also ventral. It also goes up into the lower cranial nerves, which is the pain in the neck, and you see the vertebral inside the tumor. Definitely inside the tumor, so there's certainly no doubt about it. Again, the same thing, you open up the arachnoid, you check out the anatomy, you can start seeing the nerves. Again, this thing which comes in the books, it's ventral, it's dorsal. Well, it's dorsal, it's ventral, it's a pain in the neck. It's around the rootlet, so you have to be patient. Sometimes tumors more amenable to suction, sometimes it's harder. You have to play around with these lobules, try to make the tumor into several tumors, and proceed with your dissection. So try to cut this short. Right, so here we are. There's the vertebral artery. We're going above and below. See how it comes into spasm because you have to play with the vertebral artery often, and it just doesn't like being played with. See how whitish it is, and then it goes back again to its normal self. There it is. See? Oh, look, it's included. No, it's not included. Yeah, you'll see that it was perfectly patent. It was just going into spasm. There's no way to avoid it. You can put some papaver, but you always have to play with the anatomy. It's not going to go away just by telling the tumor to go away. So again, very, very ventral. You come up very, very ventral below the vertebral, and then you're up. You're in the upper, in the lower CP angle, going on to proceeding to the foramen, jugular foramen. You freeing up the nerves. And then to make good use of the time, I will just show you the last case. This was how it ended, complete resection. Again, this lady did not have those swallowing problems. She didn't have a slight hemiatrophy of the tongue. One of the rootlets of 12 was sacrificed. And again, this is another woman. She actually worked for my sister-in-law, and she fired her because she got rid of all her kitchenware. She dropped everything. She thought she was just being, she was not paying attention. She ended up having this large tumor. That's why she was neglected. She was dropping everything. And so she had to be readmitted afterwards, of course. Again, same thing. Same exposure. It's a very good exposure. You sit there, just as you would sit for an acoustic. You take your time. Your hands are supported. Your arms are supported. There's no hassles. Again, just moving in between the rootlets. This tumor had like an exophytic component on top of everything, so you have to get rid of this. So they come in all shapes. I'll be finishing soon. You use a CUSA. This was a more fibrous tumor, one of those that you just cavitate, and you're left with these pillars of fibrous tissue that you just buzz and cut, and then proceed. Again, use your coag as much as you need. You shouldn't overdo it because again, it just blurs your plane. So just buzz whatever needs to be buzzed, and then get on with the section. The section is the essential thing, and rhythm. So here we are. And the minute you start having space, and you have CSF mixed with blood, it's no big deal. The tumor starts coming out because by now you've broken its back. It's no longer vascularized, and you can actually start pulling it out, and that's what you should do. And so that by the end of your surgery, you end up with a very large field of view, all the nerves demonstrating the normal anatomy, and with a good patient result. So in my hands, I haven't had the need to go any further for tumors which are merely intradermal. Thank you very much for your attention.
Thank you, Dr. Mandi, for your talk. Do you have any questions for Dr. Mandi?
Is it?
So in this session, we had a beautiful video of brainstem surgery, fantastic anatomical pictures and approaches to foramen magnum. And the surgeries for cligomas were no less than the Jadoo effect. Thank you, chairpersons and the speakers for this beautiful session. I request both our chairpersons to please come on stage to felicitate Dr. Sandeep Mohindra. For want of time, we are heading to our next session while Renin tea is being served outside. It's my honor and pleasure to call upon stage the chairpersons for our next session on skull-based tumors, Dr. Vyom Bhargav, Dr. Anil Chandra, Dr. V.K. Vaishya, and Dr. Prakash Moda.
Okay. Welcome to the afternoon session. Without wasting time, we're going to start the next session. I called upon Dr. Suresh Dayal, he is standing already. He will speak on demystifying the 7 nerves in vestibular schwannoma. Dr. Nair, please.
Dr. Nair is just struggling to see the projection. Come. What is that? Where is forward? I want to make it big. Yeah, you can.
Yes.
Yeah.
If this takes more time, then we'll call next week. Yeah. Yeah, next speaker.
I think we'll request Dr. Bhartiya to come on the stage and please deliver his talk on complication of pituitary surgery.
It's not open. It says you have not connected to.
First of all, I must thank Dr. Sanjay Bihari, Dr. Kuntal, and all the members of the organizing committee and SDPJ for organizing such a wonderful scientific program. Today, I will be talking on complications following pituitary surgery. My main emphasis would be on the mortality in cases of pituitary surgery. So this is our team with Dr. Vivek, who has been trained from SGPJ, and Dr. Sankal Bhartiya, trained from Calcutta, and Dr. Navneet is trained from SS Medical College. The complications have been divided like perioperative, which is less than 1 week, early 1 week to 6 months, and delayed after 6 months. These are some of the complications which have been reported in the literature, like anesthetic complications and central nervous system injury or with hypothalamic injury, visual complications, then local nasal complications like septal perforation, sinusitis, epistaxis, anterior pituitary insufficiency, electrolyte imbalance. Most of the patients after discharge, when they are readmitted, one has to look for hyponatremia, electrolyte imbalance, hypohormonal disturbance, diabetes insipidus. Then vascular injuries, particularly carotid injuries, aneurysm formation, pseudoaneurysms, and hemorrhage within and swelling within the residual tumor capsule, cerebrospinal fluid leak, hydrocephalus, meningitis, and most important is death of all. These are some complications which have been enumerated in the literature and how they have been managed. I'm not going into the details. We have experience of 297 cases of pituitary surgery, mostly transsphenoidal are 287, and we observed these complications like permanent DI in 1%, transient in 8%, meningitis in 2.8, and death in 4 cases, that is 1.3. That death was because of hemorrhage and meningitis, which I'll discuss in detail in my talk. These are some cases which are just, I'll be representative cases of what we have done, like large cellular supracellular tumor. This is preoperative, postoperative, transsphenoidal surgery. Then this is another patient with symptoms of weight gain, visual loss, acromegaly. And this is a large tumor which is going anteriorly towards frontal and somewhat lateral. So we decided this to be done by transcranial route. And this was the post-op CT on the other side, and this is the total excision with after 3 months. This is another patient with progressive visual loss, urinary incontinence. BP shunt was already done and was referred to our center. This was another, again, this is a large tumor with some lateral extension. This was the second case which I have told that which was done transcranially. And this we operated transnasal. This was residual which was left in this patient. You can see this was the pre-op and this was the post. But the vision improved in the left eye and blood and bowel control also improved. These are two cases, comparative study we did in two patients, both almost same age, same symptoms of vision and both operated twice. This was operated in 2011 and 2017, and this was operated in 2005 and 2011. And again, they had the second recurrence. This was recurrent. So in this patient, we did a craniotomy in 2019. And this was, again, this is the third time transcystoid was done. So this is this patient with 2011, 2005 MRI, then 2017 MRI, 2011 MRI. This was second, his first recurrence operated after that. This was after 8 months, some residual was left in this, and this also had some residual. Then this is the third time when they came. This was just increased in size. This has also increased in size, but the thing to be noted is that this enhancing capsule in both the patients, and this was a craniotomy was done in this patient with total excision we could achieve, and the patient did well. In this patient developed, this was the third time transcystoid developed subarachnoid hemorrhage. This is the MRI of the craniotomy patient. This was the post-op CT of the patient who developed, who was shunted and he started improving. This is just one case of transcranial. The one which I have shown where we did a craniotomy, and the third time we did the craniotomy, 2 times he was operated by transnasal approach. So this is just like any other center is doing with the bit by bit. You can remove the tumor inter-optic or the opticocarotid recess, and then once you have debulked, you can separate the capsule and gradually remove it. So I'll not go into the whole of that. So our 4 mortality cases we'll discuss fast. This is the first case presented with headache, decreased libido and lethargy. Acromegaly was diagnosed, and this was a small tumor, but post-op patient had, because arachnoid, there was arachnoid CSF leak, so there was some hemorrhage. Patient went home but had developed meningitis at discharge and came back after 12 days, but the cells were not very much, but patient had gone into septicemia and had renal failure also, and ultimately died, could not save. This is another patient with recurrent pituitary adenoma. This was operated in 2006 and then came back in 2012, and a transcystoid surgery was done and developed large hemorrhage, and he also succumbed. This is another one more patient with transcystoid, the one which I discussed just now when comparative with the craniotomy that operated in 2005, 2011 transcystoid recurrent adenoma, and then again operated. This was the MRI we have seen 2011 pre-op, post-op, and then 2017 with the enhancing capsule, and he developed post-operative subarachnoid hemorrhage, where we had to do a shunt, which he improved. Started obeying commands. But on the next day, he again developed subarachnoid hemorrhage, and then he deteriorated. So in the review of literature, these complications have been enumerated. like permanent DI about 1%, and CSF leak of 4.7%, 2.5% in our cities, and death also about 1% and 1.3%. These are some literature which say that some of the protective factors of mortality, like age and sex, and whether the patients have been on glucosteroids therapy for long or radiation therapy, have been discussed. This is a slide which is comparing the standardized mortality ratio with the general population, and the standardized this ratio is higher than the general population for mortality in pituitary adenoma surgery. These are some of the protective factors which are responsible set for the mortality, but different series have been published and they have different conclusions like age, sex, and they are not, all of them are not the independent predictive factors for mortality, but definitely more the age, and in women it has been reported that they have higher mortality rates. Also, those who have received high glucocorticosteroids have higher mortality rate, and other factors have been like pituitary hormone deficiency, whether replacement therapy has been given or not given, then apoplexy, whether the tumor size, invading cavernous sinus, its consistency, then extent of removal in the first or the second surgery, and recurrent surgery, and the size of tumor. As I said, the more bigger the tumor, there may be more. So what we felt, and with our experience, we felt that the duration of symptoms, if it is longer, the duration, this may be effective for the outcome sometimes, because the capsule might become vascular, and then there are chances of hemorrhage, and also the tumor consistency might change, and difficulty in removing from the surrounding structures. So duration also important. Duration does not mean few weeks, few months, but it has to be years, because sometimes we see patient and then they come after 10 years of, and by that time the capsule becomes vascular, they become firm, difficult to separate from the surrounding structures. So tumor size and consistency we have discussed. Then recurrence and redo surgery, as we have seen that the third time we did and we had some hemorrhages. The arachnoid, if the arachnoid, there is a tear in the arachnoid, there is CSF leak, the chances of infection are there. There can maybe subarachnoid hemorrhage, and all the vascular injuries might take place. Maybe carotid artery injury or the vascular posterior cerebral artery or some other vessels might get injured if the arachnoid is. The bleeding in the tumor bed and vessel sisters, vascular injury we have just discussed, and edge I just before that. So I personally I feel that if the, although the transitional surgery is safe and has low morbidity and mortality, most cases of mortality are because of meningitis and bleeding in the tumor cavity and subarachnoid hemorrhage and vascular injury. So it is very important to respect and keep the arachnoid intact as far as possible. This patient, this is another patient which was operated, developed large hematoma, but you can see that it is within the content, the arachnoid was intact and the patient did very well. We had to do nothing but went home nicely. So the arachnoid was intact, so the patient was intact. So the message is that try and keep the arachnoid intact. If we have to keep the mortality, morbidity low, the arachnoid is intact and the patient is intact. Thank you very much. Any question, please?
If there are no questions, we can move to the next presentation.
Thank you.
Thank you, Doctor.
It has
The
opened.
next
Yeah.
presentation is primary vertebral body tumors.
Yeah,
Yeah.
ready. This one. So sorry for the fiasco. Okay.
Tell to lower.
How to connect this one? The same thing is happening. Yeah, it does come. Make it big. Make it big. Okay. Okay. So good evening. Can you switch off this light? These lights. Come here now. Okay. So what I am going to talk to you is, what are myths? Myths are false beliefs. There are so many false things we have been taught and we have been teaching residents. Let us see whether we can demystify that. And some of the... Okay, chart is not there. Okay. So let me start. And, this is, I have operated more than 800 acoustic schwannomas with 1% mortality, large ones. And these are the ones with type of tumors all of us see in India. And so these are the myths, first itself the term acoustic neuroma was acoustic neuroma. So people used to call acoustic neurofibroma. It is neither acoustic nor neurofibroma. And initially people thought that larger vestibular schwannomas cannot be removed long back. I am talking of 120 years back. Facial nerve cannot be preserved, hearing cannot be preserved. So these myths were easily, for so many of the illustrious neurosurgeons have solved these myths. But my thing is, these things, whether CP angle area is one CSF compartment or it's multiple CSF compartment, whether vestibular schwannoma is a epiarachnoid tumor. So this is our myths only. So with this, we all think that this is a one CSF compartment. We have taught so many people, and what we have learned also it is a epiarachnoid tumor. Then whether there is an arachnoid, whether the arachnoid or the angle does it extend into the far lateral part of the internal auditory canal. And then whether there is a layer of arachnoid which separates the tumor from the seventh nerve. So Dandy first told that it can be removed, and all these great people, William House, Majid Sami, they have even told that seventh and eighth nerve can be preserved with ease. Another thing, Dandy, Oliprona, large series, 450 tumors, very early, William House, Yasser Gill. This is Leonard Malice, who also was a great surgeon from New York, and these people, and all of us know anatomy. We know about the cranial nerve, we know about the vessel, we know what can happen to ICA proximally and distally, what infarct they can develop. We know the position in the canal, far lateral in the canal. We also know the position in the brain stem, how the seventh nerve is related to the eighth nerve. All these things we have mastered. But now the first myth is whether it is a single CSF space or not. This saffron colored or BJP colored area is the so-called cerebellopontine angle area. So we know that so many cranial nerves, fifth nerve, we are seeing the seventh nerve, sixth nerve, all depicted in this picture in one CSF space. And then of course, cerebellomedullary angle is in another CSF space. But whether this is one CSF space or multiple CSF space, again, you can see the saffron colored thing is the one which is depicted as cerebellopontine angle area in all the pictures. So now just to show a video, hopefully it will run, it's not my computer. Yeah, it's running. So this is not a vestibular schwannoma. What to do now? Okay. VLC, VLC, okay. It's not coming. Coming. Okay. So this is not a vestibular schwannoma. This is a right trigeminal schwannoma. Just to show you that so-called cerebellopontine angle area. What we have learned is not one area. You can see the fifth nerve in one arachnoid cistern. Seventh nerve has been opened here. The arachnoid opened. Lower cranial nerves are in another cistern. So it is multiple cisternal spaces. This cisternal space carries with it seventh, eighth, and vestibular nerve. Fifth nerve is in one cistern. Sixth is in another cistern. Lower cranial nerves are one cistern. Can I just go out of this one? Yeah. This one, okay. So this is just to show when all these CSS spaces are opened up. This is in a vestibular schwannoma case. What is happening? Yeah. Nothing is happening here. Yeah. It's coming. Yeah. So this is, this is a vestibular schwannoma has been removed. So sometimes we remove, drill the canal towards the end. So here you can see the lower cranial nerves there. So we can see little more faster I will run. This is just to show this is the vertebral artery. This is the sixth nerve fascicles with ICA coming between the fascicle. This is the seventh nerve here. This is the sixth nerve. This cotton is over the seventh nerve. This little faster. So this is again the vertebral artery. This is the lower cranial nerves there. And this is the fifth nerve, but here just we saw that this is the seventh, eighth nerve here. This is the seventh, eighth nerve, and here we see the fourth nerve also. So this is how we open up this back. Okay. Just stay here. No, what is happening here? Okay. Now, whether the CP angle arachnoid does it extend to the far lateral into the internal auditory canal? So this is a good depiction. So this is acoustico-facial cistern, one of the cisterns in the ankle area. You can see seventh, eighth, and vestibular nerve. They extend right up to the lateral end. Arachnoid also extend. And all of us know that from anatomical studies, these nerves enter into the cistern immediately after it pierces the bone arachnoid here. There is no extra arachnoid space here. So this study shows that arachnoid extends into the far lateral end of the internal auditory canal. This is a toluidine blue stain, which shows that arachnoid is extending right up to the lateral end of the canal. And also you see a bulge. That bulge inside the arachnoid is the site of Scarpa's ganglia. And then that the site of Scarpa's ganglia is bulge inside the arachnoid. It is not an extra arachnoid structure. Now, the myth whether it is the origin of vestibular schwannoma. So this everybody knows that acoustic schwannoma arises near the Scarpa's ganglia, close to the Scarpa's ganglia. So if it is inside Scarpa's ganglia is an intra-arachnoid structure, these tumors have to arise inside the arachnoid in the internal auditory canal, as depicted. This is the site of Scarpa's ganglia, and Scarpa's ganglia is inside the internal. Now, age-old concept, what we have taught others, everybody. Vestibular schwannoma arises, this is what we have taught everybody. Vestibular schwannoma arises epiarachnoid, at the far lateral end of the internal auditory canal. And as it moves towards the angle, it carries with the arachnoid which was inside the internal auditory canal. And then when it reaches here, it gets juxtaposed to the parietal arachnoid of the CP angle, so that any surgeon who operates is through a retrolab or a retrosigmoid route. He has to peel these two double layer of arachnoid to remove the tumor. This is what we have taught everybody. But you see this picture. This is acoustico-facial cistern with the nerves there. You see a vestibular schwannoma inside. If the tumor is arising epiarachnoid, this CSS space should never have been there. That shows that this tumor may not be arising epiarachnoid. These are arising subarachnoid. And these are two big surgeons from Japan, my close friends, and lot of things I learned from them. This is Professor Kono from Tokyo University School of Medicine and Professor Ohata from Osaka City. They have described long back that these tumors may not be arising epiarachnoid. This is the concept. This is the concept which Professor Kono from Tokyo published. He put two cartoons here. One cartoon is of epiarachnoid origin, and this is a cartoon of subarachnoid origin. So if this double fold of arachnoid is peeled in this epiarachnoid tumor, you take a cut section from here, there should not be any arachnoid over the tumor, as opposed to this cartoon, where this double fold of arachnoid is peeled back. You take a cut section from here. There will be a layer of arachnoid, which precisely Professor Kono showed in most of the acoustic urinoma. He peeled off this double fold of arachnoid and took a cut biopsy of this section, and he proved that there is arachnoid over the tumor, to prove that these tumors are not of epiarachnoid origin, these are of subarachnoid origin. What is the concept? Concept, these tumors, they grow inside the canal as a subarachnoid tumor, gets adhered to the porous, superior wall of the porous. This adhesion moves in the epiarachnoid way towards the angle and later to become subarachnoid. So if a surgeon operates thinking that this is the concept, he peels off this arachnoid. There should be arachnoid separating the tumor from the brainstem. Arachnoid should be separating the tumor from the brainstem. Here, in this concept, you peel off this arachnoid. At some point of time, you have to enter into the subarachnoid space. This is what we see. You peel off the arachnoid, you enter into the subarachnoid space. There is hardly a arachnoid which separated from the brainstem. And this is the concept. Origin inside the canal, subarachnoid, behaves epiarachnoid for some time to become subarachnoid later. This is the concept of vestibular schwannoma. So this is a cartoon again, courtesy from Professor Kono. Tumor arises in the acousticofacial system. What are the nerves in the acousticofacial system? It is the seventh nerve. It is the vestibulocochlear nerve. So if the tumor arises in the system, from the vestibular nerve, the capsule of the tumor is the perineurium, this dark plate, perineurium of the seventh of the vestibular nerve. Seventh nerve is there, this yellow thing, which is adherent to the perineurium. No arachnoid there. So this is the arachnoid. It is in the subarachnoid space. Tumor arises from the vestibular nerve. The capsule of the tumor is the perineurium. And this is the perineurium here. There is no arachnoid. If you look for arachnoid, you will never see arachnoid in a vestibular schwannoma in the angle. And this is the concept, and I will show some videos. Is it true all the time? This is not true all the time. Very rarely tumors can arise from the cochlea, from the vestibular area, from the macular area, from the modiolar area, aortic area, extremely rare. Very, very rare. 2-3% it can arise like that. So this is the incision I give laziest just to show tumor decompression. All of us know internal decompression, 360 decompression. I will just show one video for want of time, and then I will just move out. This is just to show there is no arachnoid. There is no arachnoid separating the tumor from the seventh nerve. So this is the tumor has been debulked. First what I do is I have debulked the cerebellum pontine angle of the tumor. I have kept bone wax over the cerebellum to prevent if the drill slips, if the wax is there, it will protect the cerebellum. I will run it little fast. Tumor is being pulled out of the internal auditory canal now. So if you pull the tumor out of the internal auditory canal, this is the wax being removed. So you can see the seventh nerve, eighth nerve all inside the canal. So now you can see the nerves here. So this is here, it is coming very well, very bright. But here it is coming very bad actually. I am very sorry for the projection only. Now, after that, this is the tumor inside the canal. The tumor inside the canal. Now the extracanalicular part of the angle, we can see the flattened nerve. Tumor decompressed. Once you decompress the tumor folds on itself. Use that fold as a handle. Start dissecting the arachnoid. Use the sharp forces. It's called the SS forces, which I purchased from Japan. You can see this is the flattened nerve here. Inside the canal, flattened nerve. No arachnoid is separating the tumor from the seventh nerve. Let me run fast. Again, you can see the flattened nerve here. Canal. This is the flattened tumor in the canal, and this is the canalicular part. And now we will be joining. So there is no arachnoid. There is arachnoid we separated from the fifth nerve. Fifth nerve is in another system. Lower cranial nerves is in another system. They are separated by arachnoid. But among the seventh cranial nerve, eighth and vestibular nerve, there is no arachnoid. So don't try to open arachnoid in the lower cranial nerve area. Cerebellum medullary system arachnoid, you should never open, make a leak and just release here, sir. Fifth nerve also unnecessarily, fifth nerve automatically gets open, sister. But in lower cranial nerves, as far as possible, I will just pull it, stop it, let me see. Have I finished my time? 3 minutes more, okay. Stop, here. Steve, I will just, I have so many videos, but I am not showing anything. I will just show one more video if I have time. This video. This is a large tumor, right? Large tumor, you will never see that nerves at all. Till the fag, if you know this concept, you know that you will get into the tumor. This is intratumoral decompression. Second step, intratumoral. Third step, intratumoral. If you do that, this capsule will fold. Your arachnode you can peel back. So I told the dissection technique is same like epi-arachnode origin because the double fold of arachnode. So here you can see the flattened nerve. This is the fifth nerve. This is the fifth nerve here inside. Fifth nerve. This is the flattened seventh, eighth nerve. Lower cranial nerves are here. Tumor is a right-sided tumor. To your left is the fifth nerve. Middle is the flattened seventh, eighth. No arachnode is separating. Just I will wind up now so that I can take some questions. You can even preserve the hearing also sometimes. If I show you, this is one unfortunate patient, bilateral, small side, deaf, large side hearing was there. So what do you do in bilateral vestibular sonoma? Conserve hearing, till something happens. Either brainstem compression signs or hearing loses, you act. So this patient, they never wanted surgery. The tumor started doing hydrocephalus, and you can see ultimately this side hearing did, then we operated. And even we could preserve some hearing. And this patient had good facial function and some hearing. Sometimes hearing also can be preserved. So I think I will just, this is the principles, but one great man's thing. This is Professor Kobayashi from Japan. What he has told in Golden Birds, everything. This is what haste makes waste. And you should believe that you can remove this tumor. And then say, it is no traction. You should not fear that you cannot remove acoustic sarcoma. Say, don't keep on coagulating. You should never coagulate over the tumor surface. So you use that arachnoid plane and respect the arachnoid. And you know that whenever you cannot remove, just retreat. Nothing is lost there. Our aim is to say patients like, thank you very much. Over. You can take some questions. Take it out. This is my.
I invite the next speaker.
No questions, eh?
S.S. Kale.
Okay, thank you.
For his talk on primary vertebral body tumors.
Good evening, everybody. Oh, I still see some enthusiastic people. Sad end of the day. Anyhow, thank you very much for this opportunity to present this osseous tumors of the spine series from All India Institute of Medical Sciences, Delhi. It was a single center retrospective observational study done between 7 years, and the total number of patients is 100. Most of them were males, the young people in their 30s, some children and some adults. The extent of the age about 10% to 12% each. If you see the list of the tumors, the numbers, the commonest tumors, hemangioma, benign tumor, aneurysmal bone cyst, and then some chordomas, chondrosarcoma. The numbers keep falling, and we have some rare hemangioendothelioma or osteochondroma or benign chondroid tumors. So the most common ones are usually benign lesions, hemangioma, aneurysmal bone cyst, and if you make a complete excision, the patient is cured. So we stage these tumors according to the WBB system, the Weinstein-Doriani system, and this is how you divide the vertebral body into different sectors and the soft tissue around it. Depending upon which regions are involved, you stage the tumors, and the surgery is tailored according to this classification. So this tells you whether you need to do a on-block removal, whether you can do a partial dissection, depending upon what is involved. Most of these tumors are in the thoracic region. The number of vertebrae is more. The second, cervical and lumbar were equal, and a large chunk, almost 39%, were sacral tumors, right at the tip of the vertebral column. Most of the people presented with these symptoms, limb weakness, pain, numbness, and about roughly 1/4 had autonomic, that is bladder and bowel problem also. And most of these were, many of them were sacral chordomas, where the S1 roots bilaterally got involved. This was the ACR grading preoperative. Most of them were E or D. Some of them were A or B. We did intralesional resection in 33, on-block resection in 21 patients, intralesional alcohol injections. Now, this is the technique we use for hemangiomas. You open the spine, you identify the lesion, you inject alcohol so that the hemangioma scleroses. And then the danger is of the vertebral body collapsing after sclerosis, so you stabilize it after doing the alcohol injection. And then partial resection in 23 patients. So we'll see some examples. A 20-year-old young man presented with spastic quadriparesis. And as you can see, there's something going on over here. The C2 body, we don't seem to see the C2 body. Young man, so we thought it's some kind of a bone-destroying tumor. On working him up, incidentally, young people get worked up more extensively. We discovered there were lesions in other parts of the spine and the body as well, and the pelvis as well. And the biopsy, this was the primary lesion that we were dealing with, but there were lesions in other places as well. And that's how we dealt with him. We did a transoral dissection of all this mass and then stabilized it from the back. And this turned out to be a Langerhans cell histiocytosis. So that's a rare tumor. Another young lady, 20-year-old young girl. Here the C2, if you see the C2 vertebral body, the posterior elements as well as the anterior, the whole body is involved. I mean, the whole C2 vertebra is involved in this lesion. But thankfully, she didn't have many neurological deficits apart from pain. And if you see the CT scan, it seems as if the C2 is completely disappeared. It's being eaten away. Again, we did the same thing, anterior and posterior, with the stabilization of occipitocervical, with the excision anteriorly. And this turned out to be, this is the follow-up picture of this young lady. She's doing fine. And this turned out to be a giant cell tumor, a GCT. And she's doing fine after almost, I think, 4 or 5 year follow-up for this patient. 31-year-old young man presented with neck pain, no systemic symptoms, everything was normal, only neck pain. And this is what happens. This time it looks as if the C3 vertebra has disappeared completely. At least the body is gone. C1, C2, C3 is gone. This was what the CT scan looked like. The top of the C2 is still preserved, but mainly the body is disappeared. The C3 body is completely gone. This is what we did for him. We did anterior and posterior surgery, and we put in a cage to stabilize because it was the angle was too acute. He was going into kyphosis. He did well for the first 3 or 4 years, but then the lesion recurred in other places in the body. And as you would all have guessed, it turned out to be earlier was plasmacytoma, then actually became multiple myeloma. And a few years later, he succumbed. We operated this as well. We removed this and stabilized it. but then it spread to the other parts and he succumbed to his illness after, I think, 2 or 3 years after this surgery. Another D6 lesion, and it's the same young man. This was the lesion in D6 level, and he died a few years later due to systemic disease. Then we had this 51-year-old lady who came only with extreme pain. Her problem was she couldn't move her neck. She came holding her head like this. This was what the radiology looked like, and she said, "No, I don't want any extensive surgery. I'm not going to undergo any extensive surgery." So we somehow convinced her family, her husband and her children, that at least the least we can do is to alleviate her pain, and then she will go for radiotherapy. Her pain did not respond to the EBRT, and it got worse in 2018, and then she agreed for surgery. But by then the tumor had increased in size, and this was what it looked like ultimately. And her general condition was quite bad. She was unfit for any major surgery, or at least the combined surgery of anterior and posterior. So all we did was a quick stabilization of the spine, and the pain improved. The pain almost disappeared. She still had some pain, but at least the remainder part of her life was more or less pain-free. So palliative surgery. Sometimes you have to end up doing palliative surgery. Then we came across a young man who came to the casualty. He had presented to some other hospital with this tumor in 2017, and he was operated outside in some other hospital where a laminectomy and decompression was done transpedicular. The biopsy said a giant cell tumor, and he was stabilized from C1 to C4 in this manner. But the tumor recurred, it kept on growing, and ultimately he came to us where he was almost quadriplegic. So we had to do the surgery again. We undid the fixations from the back, we removed the whole tumor, we went in from the front, and we did kind of stabilization between the clivus and the cervical vertebra from the front. And this was his follow-up MRI, and it showed that almost all compression from the spine at least is gone. He improved, his power improved to grade 3/5 within a couple of months of surgery. And then he's on follow-up, gradually improving, but he still cannot walk on his own. Then we had a giant cell tumor at 20 years of age in the L1 vertebra. That's how it looked like, almost completely gone. And here again we did anterior and posterior. We had to remove wherever that was involved and put in a cage and then stabilize from the back. We couldn't remove the tumor completely. It's too vascular, bleeding too much. He lost a lot of blood. So we had to do with partial resection and stabilization anterior and posterior. And I think this is the last tumor I would like to show. Another young man came with this big swelling in the neck. I'm not showing the X-rays and the CT scans. This was what his tumor looked like. So the FNAC was inconclusive. They said, "Oh, I don't know, it looks like some, we can't comment." They couldn't actually tell us what the tumor was. But anyhow, his problem was of myelopathy and weakness in all 4 limbs, so we had to operate this. And we went in from the anterior approach, took the tumor off the vertebral bodies. I think 2 vertebral bodies were involved. The biopsy intraoperatively, when we set a little piece for a squash preparation, the only thing they could tell us that it's a benign tumor. It looks like a chondroid tumor. So we decided not to resect 3-level corpectomy from the front. This was what the other pictures look like. So we could get by shaving off the tumor from the vertebral body and putting a plate. And he did well for 6 or 7 years. For 7 years, he was fine. This X-ray is, I think, quite old, 2004, I believe. And in 2011 and 12, he came with a horrible recurrence, and it had moved the plate and the screws had come off. He had a big tumor in front, and the tumor had spread laterally and was involving the vertebral artery as well. And we tried to shave off the tumor again. We tried to remove it, but he could not make it. He was one of the mortalities in this series. Anyhow, the first picture looked really nice. This big tumor, and in the end, you get a nice picture. And he did well for a few years. These were the types of fixations which we did: anterior only, posterior only, combined about very few, maybe 5%, and lateral approach in 2 patients. More than half of them improved neurologically. 40% stabilized. Their neurology did not improve much, but they did not worsen. And 4% actually worsened in this series of 100 patients. Adjuvant therapy was given to these tumors, giant cell tumors, osteosarcoma, chordoma, plasmacytoma, chondrosarcoma. I think the proton beam has just started in India a few years ago. So some of these chordomas did not get the proton beam therapy. They got regular radiotherapy, which is not very effective. Many of these tumors recurred, and the patients either were lost to follow-up or they never came back. I assume they didn't do well. Out of the benign ones, you see hemangiomas, aneurysmal bone cysts, osteoblastoma, chondroblastoma, and all these also received some. Interestingly, one aneurysmal bone cyst, we gave repeated injections, sclerosing agent, and we could hold on, we could at least stabilize the patient, if not remove the whole thing. We could fix it from the back and stabilize the advent or the progression of the disease. So repeated sclerosing agents in aneurysmal bone cyst is an accepted method of treatment. But you have to choose the patients carefully, and you have to be very careful with the sclerosing agent. It should not go into the pod or anywhere on the dura. This series is not without mortality. After our interventions, 5 patients died because of distant metastasis, 2 died of sepsis, 1 died of perforation peritonitis, 1 had a stroke, and 1 we don't know why he died because they never had an autopsy. To conclude, spine tumors with massive or profound neurological disturbances still deserve a chance, and you can, based upon the management protocol, if you do it according to the protocol, many of these patients will benefit. You can at least improve the quality of life, if not increase their lifespan. Thank you very much for your attention.
Thank you very much, Professor Khan. Now, because of the short of time, we will have a question later on, and I request Dr. Matthew for a paracellular tumors.
Respected chairpersons, my teachers, and dear friends. Surgical management of paracellular lesions. I have incorporated my tomorrow's video into this. First of all, let me thank all the organizers for giving me this opportunity and for permitting me to incorporate my tomorrow's video into this presentation. Paracellular means adjacent to the cellular. So most of the paracellular lesions, or all the paracellular lesions, should be on the sphenoid bone. So the sphenoid bone has this much area. So the lesions may arise from the cellular. Mostly from the lateral sphenoid wing, it's unlikely to reach the paracellular region. The middle sphenoid wing, after reaching a large size and after extension the attachment, the medial sphenoid wing is from the beginning a paracellular lesion and the clinoid lesions, and any lesion that involves the cavernous sinus. The clinical presentation is varied, and the clinical presentation decides the size at which you will get the lesion. If a lateral sphenoid wing lesion reaches here, it will be a very large one, usually present with ICC. When the middle sphenoid wing lesion gradually involves and reaches the paracellular region, again it is likely to be large. The medial sphenoid wing you may get them at an earlier stage because it involves the optic apparatus. A spheno-orbital lesion may be quite small, but will present with proptosis and visual symptoms. Trigeminal choromas most often with a deficit or with mass effect. Cavernous sinus lesions with pain and proptosis, while paranasal sinus lesions will present with pain and discharge. and often visual improvement, visual deterioration. So for a surgeon, from a surgeon's point of view, what matters the most is the plane and the tissue of the. So there may be paracellular lesions, maybe of cellular origin, pituitary lesions of craniopharyngiomas, cavernous sinus lesions of hemangiomas, aneurysms of fistulas. Lateral wall of the cavernous sinus, there is the trigeminal tumors. Dural lesions, there is meningiomas of the medial sphenoid wing. Bony lesions, there is chondrosarcomas and chordomas, and sphenoid sinus granulomas and carcinomas. I will tackle these. I will primarily concentrate on the lateral wall of the cavernous sinus and dural lesions, because that epitomizes most of the surgical technique involved in paracellular lesions. This is all the paracellular lesions. This is medial sphenoid meningioma, which is very large proportion. It's a pituitary tumor, which is extending into the paracellular. There's a chordoma, which is arising from the bone. This is a trigeminal schwannoma. I'll show this operating the surgery for this lesion. This is an aneurysm, which is within the cavernous sinus, and this is a hemangioma, cavernous sinus hemangioma. Characteristically, it will involve the entire cavernous sinus, but will extend to one side. So for a paracellular lesion, the investigation that is sometimes warranted, if you feel that it is something other than a trigeminal schwannoma, is an angiogram. Here this is an angiogram in a medial sphenoid meningioma. You can see that the vessel is not tapered, it is not irregular. That means this is a positive answer. That means you can do a curative job. If this vessel is irregular, and if there is blush arising from the ICA, be cautious, because very often you may have to be a little palliative. Cross circulation is another next important. So I will show two videos. One is actually of a trigeminal schwannoma, which is the lateral wall of the cavernous sinus, where you require mobilization of the interdural plane, but you need not go interdurally intentionally. So this is the steps of it. First, create an interdural plane. You can see the V1, V2, but you need not remove the anterior clinoid process. So this is the procedure for a So all the paracellular lesions require some form of an extradural exposure, and some of them require an interdural work. So this is trigeminal schwannoma. Most often you will be able to tackle with an extradural exposure. You can see the divisions of the trigeminal are being exposed. The brain is made wax by a lumbar vein. Is gradually being pulled away. It can all along, it can be pulled up to the Meckel scale. I prefer to expose the Kawasai's triangle also in most trigeminal schwannomas, because you want to extend it. If something is still remaining in the posterior fossa, you can always access it. So you can see the divisions of the trigeminal. The lesion is getting exposed here, and you can see the bone is being tackled with the Cusa. So the realization that there is two layers of dura in the middle fossa, adjacent to the sella, extending up to the Meckel scale, is perhaps the most important anatomical knowledge that is required for a surgeon operating on a trigeminal schwannoma or a lateral adhesion on the lateral wall of the cavernous sinus. Many of the smaller branches of the smaller fascicles of the trigeminal nerve can often be protected. You can see I have not made any intentional neural opening, but I am starting to see the posterior fossa. Anyway, I have kept a reserve of the Kawasai's triangle I can drill and access the posterior fossa if required. So that has been removed. This is the remnants of the trigeminal nerve, and that's the GSPM that is being shown. So this is regarding a medial sphenoidal meningioma. There is one more additional step required. This is a large lesion. Cross circulation is not there. This is not involved. The ICA is not involved. So the step is a little more than this, than the previous case. An interneural plane is to be exposed. The clinoid has to be removed. Then you may have to open the dura, the external ring of the cavernous sinus will have to be opened, and the incision carried along the carotid-ophthalmic membrane, missing the third nerve, and taken into the middle fossa to make a grade 1 excision. So this is the first step. So we have, this is the craniotomy has been done. The wing is being exposed. You can see with the blade, with assistance of a blade, I am developing a interneural plane. It will bleed badly, need not bother much about the bleeding in this stage. With all the blood supplies coming from the base, you can see the divisions in the trigeminal, the going into the foramen rotunda here, immediately the first division. Now the I'm removing the clinoid. I prefer a single piece clinoidectomy. It has started by deroofing the optic nerve, and this incision is deepened and carried along the whole length of the whole breadth of the clinoid. And it deepened. Just that's the strut. Now it's being broken off. So all this blood flow need not be bothered. In a single piece clinoidectomy, you can do it reasonably quickly. So the part of the strut is also coming out with the clinoid, you can see. It is gently manipulated out. You shouldn't pull, you should gradually make it perfect out. At this stage, you can coagulate the dura and pack this gap, this bony gap, and the middle fossa base with some fibrillar. This is the cuff problem bleeding. So next stage is to open the dura. You can see this being decompressed. You can see there is the ICA, the MCA, the branches being dissected free. We know that there is no direct involvement, it is only engulfing from our angiogram. Sharp dissection is a must. Lesion is largely eased away. You can see the ICA here, like their ICA is free. And sister of the optic nerve. This is the olfactory and the optic xenon descent. The next step is to remove this dura. Now we have removed the clinoid, and we can now excise the dura. You can go from medial to lateral or lateral to medial. If you have plenty of space, you can go lateral to medial to plan the extent of excision of the middle fossa. If the brain is a little tight, it's better to go from medial. You can see this incision is being taken along the base, along the carotid-ophthalmic membrane, avoiding the third nerve, taken very close to the ICA, opening the ring, and then completed towards the frontal convex. So this is a great one excision. You can see the structures, the ICA, the ophthalmic and the optic. So this is a post-op scan. You can see this being removed. Thank you.
So we are come to the end of this session. Thank you for all speakers. And there is no other question or no comment, then we can conclude here. Thank you.
Thank you very much, sir. I request Chairperson to please stay on stage for felicitation. Now I request Dr. B.K. Vaishya, please felicitate Dr. Suresh Nair. Thank you, sir. Your talk has really motivated us to further explore the mystery of seventh nerve in vestibular schwannoma. Thank you, sir. Now I call upon Dr. Vyom, sir, to please felicitate Dr. Himmat Bhatia. Thank you, sir. Now I request Dr. Anil Chandra, sir, to please felicitate Dr. Sharad S. Kale, sir. Thank you, sir. I request Dr. Prakash Mura to please felicitate Dr. Matthew Abraham. Now I request Dr. A.K. Jaiswal to please come on stage and to felicitate our chairpersons. I request Dr. A.K. Jaiswal to please felicitate Dr. Anil Chandra. Now I request Dr. A.K. Jaiswal sir again to please felicitate Dr. B.K. Vaishya. Thank you, sir. Now I request Dr. A.K. Jaiswal sir again to please felicitate Dr. Vyom Bhargav. I request to please felicitate Dr. Prakash Mura. I request all the participants who are there for award session tomorrow to please register their presentations with the preview room. Today we had gained a lot of wisdom and knowledge through the words of our masters. It feels best. It feels that the best take-home message for today was like to know the changes while to remember what remains. Thank you very much. The vehicle for the following dinner